We have really nice machines for the investigations, and we have also for treating laser machine. So far, as a clinic, we have more than 80 employees working only for Kabgayi Eye Unit, not for the hospital general, but Kabgayi Eye Unit. So they are divided in different groups. So far we have 5 ophthalmologists working on a permanent basis. There is 1 optometrist, and I could emphasize that we have 4 low vision therapists, and I think this is the only place where you can find the low vision services. So what are we doing? Consultations from Monday to Sunday, eye surgeries. You see the numbers, 25 to 40 cases may be operated on daily basis. But on top of that also we have the specialized eye examinations, as you saw the machines. Very important point is we do also the capacity building for the other staff, not only for Kabgayi, but also working in the different hospitals. If someone works in a different corner, is always welcomed to get the skills at Kabgayi. And I'm sure most of Rwandan ophthalmologists sitting here came to Kabgayi for that. The OCOs as well. We have what we call the specialties, the retina services, retinoblastoma treatment, this is an eye cancer, pediatrics, of course, and low vision and rehabilitation. As you saw in the first presentation, we are dealing really with those people, population with low vision, so that we can try to assist them, among the others. Oh, sorry. Could you go back, please, Patrick? Back. Okay. Our key achievements, I may just show you how we developed. As you may see, when you go back some years back, we have really a small number for consultations, but today we can reach easily more than 40 people who are coming for eye consultation at our unit. Surgery as well, per year, we can just perform more than 6,000 of eye surgeries in our institution, but this includes the operations done here at Kabgayi, but also during the outreaches. And outreaches may be organized by the government, as we have a national plan for outreaches, but also some outreaches organized by our partners. So beyond the consultations we are doing at the hospital, beyond the good surgeries we are doing, we didn't forget the community. Why? Because some of the people, if they come and tell you are blind, what is next? Most of us, we don't have an answer. So we tried to try a model where for those who are going to the community, if we can assist. So then we collaboration with some partners, we are sending those young people based in Muhanga who are blind to the schools, different schools. Children are sent to the School of Blind, but also then young people, there is a training center in Masaka where they can learn some activities even if they are blind. So we are really collaborating with the district of Muhanga so that if anybody comes and is blind, we don't say it's over, go back to the community, but to see, also to work on the potentials of that particular person who became blind. And then we send them to the school. We have really good results where around 10 already finished the data trainings, and now they are really doing well back into the communities. My special thanks to our partners, So far we have financial partners who are supporting us every day. Those are CBM, Right for the World, and the CO Foundations. They are really helping us to achieve what you saw on my previous slides. Coming to this conference, our gratitude goes to the government of Rwanda. Look how we are sitting here peacefully. I hope all of you had a good journey from your place to here. This is because of our government. But also, the support we got from the diocese. From the beginning, when we had this idea, the bishop was really very supporting. This is only why today we are sitting here. To the team of Kabgayi, ophthalmologists, and others who have been working very hard. To our society, but also to everybody here who accepted to come and contribute. Thank you very much. But also, I thank everybody who contributed financially. As you may see there, we got the financial support from CBM, Light for the World, Agalwari's Eye Hospital, Orchidia, CU Foundation, Belfast, Amvision, Novartis. Everybody here listed contributed so much to make this event to happen. Thank you very much. And also, I can't forget our keynote speakers. Some of them, you will see them, but really thank you very much for accepting to come and present, share your experience. Thank you for your kind attention. So, we may be happy to hear a talk from the president of COEXA.
Good morning, everybody. The Bishop of the Diocese of Kabgayi, all speakers, all delegates, all protocols observed. I'm, as Theophile said, I'm the president of the College of Ophthalmology of Eastern, Central, and Southern Africa, which comprises 12 countries, including Rwanda. And our annual general conference as a college takes place in August, but we encourage all countries to have their own national conferences that we, from time to time, attend in other countries. So Rwanda Ophthalmology Society was among those who have not managed to do this. And with Kabgayi now taking the lead, I hope to see in the near future a collaboration between Kabgayi and ROS to make it one big national conference at the same level as what we see in other countries within COEXA. So for us, it's a pleasure to be here. It is a development for the Rwanda Ophthalmology Society in general, of which I'm a member. And we hope to see this growing into a big conference annually. This is, as a beginning, this is big, and this is important to have all these speakers from different countries, delegates from different places, and I think it will be a good conference, and I congratulate you for this. Thank you.
Yeah, good morning, everyone. Bishop, Vice Mayor, my peer and colleague, Dr. Theophile, and my president. It's a pleasure to be on stage with you. I really must congratulate the whole team that put this conference together. For me, as a president of the AOC, I see this as a mini AOC because the way the African Ophthalmology Council is constituted is it includes all eye care workers, from nurses to optometrists to OCOs to ophthalmologists. And that's what I see in this room. So this is good practice for us because the first AOC face-to-face conference will also be in Kigali. and I invite all of you to attend. I hope, Theophile, your sponsors, you left something in their pockets so that they can also support us. But definitely, I'll also be calling on the team that arranged this Congress to support us as we do the same in July. And I don't know whether you know that Michael is also a vice president of AOC. So thank you for giving him the practice so that he can now put it into practice in the AOC. As president of AOC, this is my first conference in Africa to attend, and I'm happy that it is in a Rwandan conference. And just thank you to the delegates. I've really enjoyed the presentations this morning. Thank you.
Yes, thank you so much. You cannot leave the stage without hearing for our guest of honor. And it's my pleasure to invite, to give a floor to the Vice Mayor to share his address to us, and then we'll be followed by the Bishop to conclude. Thank you.
Dear Bishop of Kabgayi Catholic Diocese, dear Madam President of the African Council of Ophthalmology, dear President of COESA, dear Chairperson of Rwanda Ophthalmology Society, Director General, Kabgayi Hospital, ladies and gentlemen, estimated guests and distinguished participants, good morning. It is both an honor and a privilege to welcome you to Muhanga District for this prestigious international conference on eye care. Today, we got here not just individuals, but as a collective force driven by shared passion and committed to deliver. In a world that is constantly changing, where borders shape and ideas exceed geographical boundaries, it is only fitting that we come together in this global forum to exchange knowledge, foster collective and collaboration to shape the future in the health sector. The diversity of perspective presented in this room is a testimony that the global community and the wealth of experience that contributed to the advancement of the eye care. So being in Rwanda, it is another privilege as we promote the well-being of our visitors, and we have no doubt that each and everyone here is safe. Muhanga District, as a satellite city, we are privileged to have an important partner in the health sector, like Kabgayi Diocese, with a nice hospital, as Dr. Theophile presented the progress of this hospital, that offers a comprehensive and inclusive eye health, up to now as a referral center of eye care. So dispute carrying patients, they now reached another level of organizing such event, which I think is the first ever international conference organized by Rwandan team, and also not in Kigali. As we all know, some big conference like this that happened to Kigali, but now it has happened outside Kigali. Join me to congratulate the Kabgayi Unity team. Yes, thank you, they deserve it. As we embarked on this journey of exploring and discovery, let us remember the power that lies in collaboration. Our collective efforts have the potential to drive innovation, spark positive change, and address the challenges that our global society faces. Let this conference be the idea of inspiration, a platform for exchange of ideas, and a catalyst for transformative action. May your time together be marked by fruitful conversations, meaningful connection, and shared commitment to making lasting impact. I wish you all a nice day and lovely moments throughout this event. I hope you will not regret having come here. Thank you very much for coming.
Dear Vice Mayor, dear Director General of Kabgayi Hospital, dear President of the African Council of Ophthalmology, dear President of COEXA, dear President of the Rwanda Ophthalmology Society, dear Medical Director of Kabgayi Eye Unit, distinguished guests and friends, ladies and gentlemen, good morning. It is for me a pleasure and a great honor to welcome you all here today. On behalf of Kabgayi Diocese and Kabgayi Eye Unit, I extend a warm and heartfelt welcome to every one of you. We have gathered here for an international conference on eye care, which is organized by our Kabgayi Eye Unit. As a church engaged in integral development of human being, we are very blessed to have such a hospital where everybody, Rwandan or not, can get comprehensive and inclusive eye care. This conference is the fruit of a good collaboration between different partners here represented. It bears a precious opportunity for us to come together, share ideas, build connections, and learn from each other. If we look around this room, we can see a diverse group of individuals from various backgrounds with a wide range of experiences and expertise. Your presence here today is a great sign, a great testimony to the importance of this conference and the common goals and values that bring us together. Throughout this day, we'll have a privilege to hear about some different experiences engaging in meaningful discussions and opening new opportunities. Ladies and gentlemen, I hope that you will leave here inspired, enlightened, and with a sense of comradeship that will last beyond this conference. I would like to take this moment to express my gratitude to all those who have worked tirelessly to organize this important meeting, and those who took their precious time to attend. I thank all the partners who financially contributed to making this event be organized. We can't forget to thank all the companies that are exhibiting. Dear companies, your support in eye care is unmeasurable. Thank you for being here. Ladies and gentlemen, let us make the most of this day, seizing the opportunities it offers. And let us also remember to enjoy the journey together, the conversations, and the connections we'll make. Yes, together, we can create a brighter and a more promising future for eye care in Rwanda and worldwide. I wish you a successful conference as well as a productive, inspiring, and memorable day. Let us get started, and God bless you.
Thank you so much, Bishop and our guest of honors for their keynote address. But before they leave the stage, I would like to invite our presenters and our dear ophthalmologists to step forward for a group photo before our guest of honors leave. Please, let's do it quickly. And our media team, please be ready to guide them on how to stand so we can have a better picture. Thank you.
In a crowded room, you look so happy when I'm not with you, but then your song.
I think we all captured one message from them. So the next session is going to be moderated by Dr. John Cropsey and Dr. Michael Mikhail. I hope I'm pronouncing this well. The session includes 5 presentations. And as you remember, please, as they present, note down your questions. We'll have a Q&A session after the presentations. Dear Dr. Cropsey and Michael, the floor is yours.
All right, ladies and gentlemen, welcome to our second morning session of the Kabgayi First International Conference of Ophthalmology 2024. It's my distinct pleasure to introduce my boss, Prof. Shiku Metenge, who will be enlightening us with their expertise on the topic of artificial intelligence in ophthalmology screening. Prof. Chiku is a senior ophthalmologist subspecialized in medical retina and community ophthalmology. Prof. Chiku serves on multiple distinguished advisory boards and holds the distinction of being the first African woman on the ICO board. Currently, she serves as the president of the African Ophthalmology Council. She's the co-founder of the Rwanda International Institute of Ophthalmology, where she serves as Director of Training and Research. Prof. Chiku has authored many peer-reviewed papers, including pioneering the first use of AI in diabetic retinopathy screening in sub-Saharan Africa. Please join me in extending a warm welcome to Prof. Chiku as she takes the stage.
Thank you very much. You'll notice the topic of my talk is a bit different. I decided to go a bit broader, especially in recognition that our attendees are not just ophthalmologists. So rather than sticking to diabetic retinopathy, I will talk about AI in ophthalmology a little more broadly. I hope you don't mind, Dr. Mikhail, and you indulge me. Yeah. I cannot miss the opportunity to just advertise the conference again. So the dates are July 27th to 29th in Kigali. And this will be the fourth conference for the AOC, but the others happened during COVID, so this is the first in-person conference, and you're all welcome. So raise your hand if you do not use software. Never used any software. So a few years ago, software was the AI. That was the discussion going on. And Mark Anderson, who is a venture capital investment person, authored a paper that said why software will eat the world. And it's that title that inspired my title for this. Because I think what he was discussing then about software is what we should be discussing now about AI. I think we just haven't started using AI as much as we should, but we will. And one of the most interesting things about AI that I read about recently was about what is called digital olfaction, which is the wine industry is really, really plagued by fakes. So people will produce cheap wine and put it in nice bottles and say they are from these vintage vineyards. And for those who know about wine, that's not a good thing. And now they're using AI. I've taught AI how to detect just by presenting the wine to AI. AI will tell you which vineyard and which year. So this is going to save the wine industry millions of dollars. But if we can teach AI to smell and taste, then what can we not teach it? So, for, again, the sake of my residents, my OCOs, what is AI? And I tried to summarize the whole of AI on one slide. So when we talk about artificial intelligence, we are basically talking about trying to replicate our own human intelligence, and we do this by simulating its functions using computer systems. Together with AI, you'll hear of words like neural networks, computer vision, machine learning. The easiest way to think of this is these are subdomains of AI, and these subdomains are the pathways towards the ultimate goal of what AI will do. When you talk about machine learning it's fed by data. And using software algorithms, machine learning looks at data and it learns how to identify patterns and analyze that. And not only does it identify patterns, it learns. When you talk about computer vision, this is using data that is of a visual format. So videos, images, and then extracting useful information from those images. Today in places like China, they have AI on the streets that can identify every citizen. It can tell whether it's a male or a female and other things about you. And that kind of thing is possible in societies where the public is not always taking the government to court, like Kenya, where I come from. And so I think that places like China will really move forward with AI because the community is more permissive of government to be more innovative and to be more flexible in what they're doing. When you talk of neural networks try to act like our brain. So our brain is made of neurons that one neuron will connect with another one. And really neural networks are using mathematical functions that are connecting to each other and therefore kind of simulating what our brain does. And that is what AI is. It's all summarized in that slide. But what AI does then is that it applies all this learning from all those different sources and learns to make better and more reliable decisions. The thing we wish all our students would do. The more you teach them, the more they are making better decisions. And then it learns to analyze these patterns, and it makes corrections, and it can even make predictions. Those are the unique things. And this ability to make corrections and predictions and make itself better is why there's a lot of debate about where is AI leading us. So I thought I'd put in one slide about the difference between artificial intelligence and smart systems. And one of the smart examples I put is this algorithm that is part of the primary eye care curriculum that I helped develop for WHO for Africa, and this is the red eye algorithm. So when something is smart, it relies on the algorithm, but it does the same thing every time. Using this algorithm, the nurse can follow and ask, is it a red eye with itch, a red eye with discharge? But at the end of the day, every arm of the algorithm will lead you to the same thing all the time. AI is not like that. AI means that after some time, the AI starts saying, hey, despite the fact that it was a red eye with discharge, there are these little bumps I see on the lid, and if these are called follicles, it learns now to differentiate follicular conjunctivitis from other conjunctivitis. And every time it's seeing these patterns that are repeating, it starts interpreting them and creating better solutions. So that's how I would say is a difference between smart. We have to be careful about AI, and I just put this example of when BARD started. BARD is the AI, the competitor to ChatGPT, and now it's just changed its name to Gemini. But this is just something I picked off the net, where BARD was asked if the first 2 months of the year are January and February, what are the other months? And it said January, February, March, April, May, yeah? So AI is not infallible. It can make mistakes, and we need to be conscious of those things. Some of the things that are worrying big firms, even like Microsoft and Google, is things that we call hallucinations. Hallucinations are when people make errors with confidence, yeah. I am familiar with that because I have a son who's 16. And I remember one time he was writing an essay. He had a homework to write about the internet. And it was, what is the internet used for? And he was very quick. And I said, why are you done? And he said, yes, I'm done. What did you write about? I was surprised that he could write an essay on the internet so quickly. And he said, oh, I wrote about the internet is a tool used for online dating, which worried me. He was 10 at that time. I said, what do you know about online dating? And he said, online dating is good for people who don't have friends, because they can meet other people who don't have friends. I said, okay, and what else did you write? I said, and it's also good for people who don't like their faces, because they can put any face on the internet. And I said, are you going to submit that? And he said, yes. So, yeah, making errors with confidence, hallucinations. And you know, this is an example of a hallucination that can exist, and we need to have tools to identify that. The other thing worrying internet AI developers now is about emerging abilities. And this is that the AI learns to do something you didn't teach it. So one of the things that Google, for example, found is that you teach a program to translate languages, and then you find it's translating languages you never taught it. So that's a bit worrisome, because that can go off in any direction. So AI is good, but it's not infallible. Let me come back to ophthalmology. So in ophthalmology and other specialties, we are increasingly becoming subspecialists. And I think our patients really don't care about those kind of things that we keep doing in subspecializing and keep going lower and lower. But for me as a comprehensive ophthalmologist, even though I have medical retina as my subspecialty, I still have to deal with patients who have glaucoma, for example. And as a comprehensive ophthalmologist, I can extract some news from a visual field printout, but I'm sure I'm not extracting everything. But I believe in the future, AI will help me probably to extract 100% of what the printout is telling me. By the same token, I hope that OCOs, optometrists, will also learn to extract 100% what this fundus image is showing us. And my interest in AI started when I really had no interest in AI, but I had done a big study in Nakuru looking at retinas in African eyes, and so I had this cohort of 5,000 images from African eyes that were curated and graded by Moorfields Eye Hospital. That's how I met Tunde. After a few months, she said, could I use your images for something else? And the people on this paper are some of the architects of the first FDA-approved AI system. And you know, getting such a huge database of images from a very unique population was very useful for them, and that was my first publication. Our most recent work happened just published 2022, and this was a randomized trial looking at the impact of using AI, because there's a lot of stuff around using AI for screening. But I felt it's useless to screen if those patients are not going for services. And that's what we wanted to look at. Does AI improve their uptake of care? And we found that it did by 30%. We had 5 screening sites, and we were lucky to work with an AI manufacturer who could allow us to customize, produce our own reports, make them very visual. We had a Kinyarwanda interpretation of the results. And we honestly think in a country like Rwanda, where there's no national screening program, we'll just jump straight to AI. We just do not have enough ophthalmologists to go any other pathway. My first gift today, I have 2 gifts for you, is CyberSight AI. I will not show this video because I'm conscious of time, but basically it was a video to show you how CyberSight AI works. It's free.
In this short video,
You can present any image to it, and it will give you an interpretation within 3 minutes. So if you go to that URL, anybody can present fundus images to it, and you will get your interpretations free of charge. CyberSight AI is what we used for our study. It's a product of Orbis International. So, can AI be a disruptor in ophthalmology? This is the eating part. Will it eat us up if we don't eat it up? I think so. And Clayton Christensen is credited for being a guru in disruptive technology. And he has a formula for checking whether a technology will truly be disruptive. And I used that to look at some of the things we have in AI in ophthalmology today. So does it target non-consumers or low-end consumers? Yes. In our case, we are few specialists. There's a lot in ophthalmology we are not delivering. If AI can help us fill those gaps, we will definitely grab it. Is the innovation simple, more convenient, more affordable than existing options? Absolutely. I used to go to the Rwanda Diabetes Association. I could only go twice a year to screen their diabetics. Now we've put a camera there with AI. Don't have to do that anymore. And the cameras are becoming simpler, cheaper. This is our DRS camera at our Rio Eye Hospital. And it's just so simple. In 3 minutes, you have a nice printout like this. It's easy for the patient to understand. The camera looks nice. Like, what's not to like, yeah? So can AI become a disruptor in terms of, does it have a steep improvement trajectory? Absolutely. AI in ophthalmology is going so fast. We started with diabetic retinopathy. Now Altis has a really good platform where they're using AI to read OCTs. And because anybody can buy an OCT machine, I think a lot of the other fields in ophthalmology will buy these OCT machines and use AI platforms to interpret. Is the innovation being developed by an organization whose business model allows it to be sustainable at lower gross margins, in other words, not make a profit from it? Yes, because it's not being developed by healthcare industry, it's by the IT industry. And they know how to do this. They know how to do things at scale, and they don't have to worry about the margins. And Altis, for example, is a company where it's an ophthalmologist and an IT person.
they're doing this almost as a hobby. They're not worried about the margins. And I think because of that, it will disrupt ophthalmology. This is one of their products, and they make it really easy. Present an OCT scan. They have a grading scale that can look at edema, at degeneration, at exudates, and you just need to present your OCT, and it will tell you what is on the OCT. So interesting cases, a man with previous CSC. If I ask my residents what is this, they will say it's a recurrence of the CSC. The AI said there's also macular degeneration because it could see disruption of the RPE, and it highlights that. And so it's not a simple CSC case, it also has some macular degeneration. So I think AI will really disrupt even our roles as specialists. So is the market incumbent, us, motivated to ignore the innovation? Yes, and many of us are. And because of that, because we tend to like things that sustain us, we want faster lasers, we want more complex imaging systems, we don't look at disruptive technology. We're a bit scared of disruptive technology. Because of that, what happens is other players who are not like us will run with this technology, and it will become the in thing. And finally, is there a technology enabler to carry it in the upmarket? Absolutely, the internet. Because a lot of these AI platforms are on the internet. If you can scan that QR code, is my next gift for you. It will take you to the Altis OCT free education program, and you can download this on your phone, and it will teach you about how to read OCTs, thousands of OCTs, all types of pathologies. If this is already available, for sure, this will be a disruptive technology. As I come to the end of my talk, I have to say AI will also run, it will eat us if we don't eat it, because we are so faulty. This is a graph of human error, medical mistakes that we make as clinicians. And the largest group is incorrect diagnosis, followed by treatment errors. This is others, yeah. So this is the distribution of those errors. How many are they? In low and middle income countries, in 1 year, I forgot to put the reference, 134 million adverse drug effects, leading to 2.6 million deaths from our mistakes. Current AI systems are about 80 to 95% accurate. And when they are 80, they are beaten a lot, yeah? Yet we are doing this. So if these AI systems become more accurate than ours, for sure they will eat us up, okay? I think AI, I'm an educator also, will also change the way we approach pedagogy. So this is a wide field image presented to AI. It will identify that little hole in the extreme far periphery. I'm wondering in future, do I need to struggle to teach residents like Ellie and David how to do an indirect ophthalmoscopy if this technology becomes easily available and even more accurate? I think the way we teach will definitely change. So I think with AI, some of our jobs in eye care will disappear. Other jobs will grow based on those who eat this technology and innovate with it. But definitely all of us, our jobs will change. So it will change the way we practice ophthalmology, not just because of the way we will engage with AI, but because of the way our patients will engage with AI. If Google was bad enough, wait till AI is out there. So that was my last slide. Thank you very much for listening. And again, see you in July at the AOC conference.
Thank you very much, Professor Chico, for such a fascinating talk. And thank you for the 2 gifts. It will be appreciated. So, ladies and gentlemen, it is my distinct pleasure to introduce to you my good colleague, Dr. Levin, who is going to talk to us about diabetic macular edema management challenges and opportunities. Dr. Levin serves as a consultant ophthalmologist at Kabgayi Eye Unit. Please join me in extending a warm welcome to him as he takes the stage.
So good morning. So we are going to go through diabetic macular edema management challenges and opportunities. So diabetic macular edema is one of the leading cause of poor vision diabetic patient. And many patients will need many injections until the edema resolves. And in others, the edema will recur after stopping injections. So treatment options include intravitreal anti-VEGF, intravitreal injection of steroid, and laser. So we have challenges, and the most challenges to diabetic macular edema treatment will be poor glycemic control, poor blood pressure control, recurrent edema after stopping injections, and availability of other anti-VEGF, and the high cost of anti-VEGF and the storage of anti-VEGF. So we have different anti-VEGF in use, such as Avastin, Lucentis, Eylea, brolucizumab, and the faricizumab. So this study done to assess the efficacy, safety, and tolerability of anti-VEGF, including brolucizumab. And at 1 year, brolucizumab was a bit better or equal to Eylea. But at 2 years, the results were the same. And the adverse event were comparable in both. So there is another study, Kestrel and Kite. In Kestrel, brolucizumab was compared to Eylea, and the brolucizumab was given 3 milligram or 6 milligram, 5 doses, a loading dose every 6 weeks. And there was a maintenance dose at week 12, after 12 weeks, or 8, depending on disease activity assessment. And the Eylea was given 2 milligram every 4 weeks, 5 loading doses, and maintenance dose after 8 weeks. And the results were almost similar in both groups. Yes, the results were almost similar. If you can see, there is no great difference in terms of central subfield of view thickness and in terms of change in the baseline visual acuity. In this slide analyze, this was ranibizumab 0.3 milligram versus 0.5 milligram. And in this study, laser was available in a case. Here, the median number of injections was 24, and the number of macular laser was 1.8 and 1.6 in sham and 0.3 to 0.8 in ranibizumab. So the results in terms of visual acuity and in macular thickness were almost similar. So there is another study done to compare Eylea, bevacizumab, and ranibizumab. And as you can see, the change in visual acuity from baseline, there was improvement from 10 to 12.8 letters. And the main central subfield thickness ranged from, the decrease ranged from 126 to 171. There is no great difference. So there is another study with ranibizumab and the prompt laser or ranibizumab with deferred laser. So in this study, laser decreased the number of injections needed by 4. But the results in terms of visual acuity and anatomical, that means subfield for view thickness, were the same. Either laser was done promptly or was deferred. So there is another network meta-analysis comparing the 3 most used anti-VEGF, Eylea, ranibizumab, and Avastin. In this study also, the results were not statistically significant. There was no difference in terms of visual acuity and in terms of macular thickness. So what is the situation at Kabgayi? So last year at Kabgayi, we injected 140 Avastin, intravitreal Avastin for diabetic patient with macular edema. So the number of injections ranged from 1 to 18 with a mean of 2.74. And the macular edema clinically resolved in 77%. So around 53 got Avastin only, and 36 got Avastin and focal laser. The minority got Avastin, focal laser, and triamcinolone. In terms of visual acuity, at the beginning, visual acuity was 0.68 logMAR, and at the end, visual acuity was 0.47. That baseline VA is around 636 to 624, and the end treatment VA was around the 612, between 612 and 615. The central subfield thickness mean was 408 at the beginning, and at the end, it was 296. So in our settings, we have Avastin as our main treatment for diabetic macular edema, but it is not enough. So we have other challenges that we have seen, including lack of other anti-VEGF and the cost. So other options, including focal laser or grid laser, should be explored to answer all those challenges. So thank you very much.
Thank you. Thank you very much, Levin. Ladies and gentlemen, it is my distinct pleasure to introduce to you Professor Naomi Lois from Belfast, UK. She is going to talk to us about proliferative diabetic retinopathy complications and treatment. Professor Lois is a professor of ophthalmology at Queen's University in Belfast and a VR surgeon at the Belfast Trust. She is fellowship trained in the top-notch eye hospitals in the world, including oncology training at Wills Eye Hospital, medical retina at Moorfields Eye Hospital, and VR surgery at Liverpool University Hospital. She has advised the UK government as a member of NICE Technology Assessment on the introduction of new treatments in the UK NHS and developed national guidelines for diabetic retinopathy. Now she's leading a program of preclinical and clinical research focused on diabetic retinopathy and its complications. She's published over 160 articles in peer-reviewed journals, 13 book chapters, and is the editor of 3 textbooks. One is in its 2nd edition. She's also been a chief investigator in different high-yield multi-center clinical trials, among others, for example, FILMS trial in macular holes, Emerald and Diamond studies on diabetic retinopathy. She's also the chief investigator of an ongoing multi-center randomized trial called DAME trial that's comparing anti-VEGF versus micropulse laser for diabetic macular edema. So without any further delay, please join me in extending a warm welcome to Professor Lois.
Thank you very much. Thank you very much, Michael, for the introduction. I hope that you can hear me well. Is it okay? Thank you. I think this is better. Good morning to everyone, and thank you very much for the invitation, and thank you to the organizers of this amazing meeting. And I must extend also thank you to the Kabgayi Eye Hospital family, I would like to say, rather than team, because that's how I have felt since I arrived here as part of this wonderful family who actually are working so hard and with such an expertise and care for their patients. It's been a fantastic week. Thank you very much. I could say a lot more, but I cannot because of the interest of time, but thank you. So what I like to do during the next approximately 20 minutes is to provide you with some evidence and also some of my experience or the way in which I see things on the different topics on proliferative diabetic retinopathy, including prevalence and risk factors, prevention, treatment, and then go into the complications and how to manage these complications. So with regards to prevalence and risk factors, I just would like to share some studies that have been done here in Africa on prevalence of PDR. And the prevalence varies from looking at people with type 1 diabetes or type 2 diabetes, and this is specifically of PDR, not any retinopathy, because not all patients with diabetic retinopathy will end up developing PDR. So you can see that it goes from low in Ethiopia in type 2 diabetes, 3.6%, to very high in Cameroon in people with type 2 diabetes, with 36.6% of people developing it. There was some years ago what we call a individual participant data analysis, in which they obtain all data from every single participant that was part of these 35 studies that were conducted in USA, Australia, Europe, and Asia. And they found that the prevalence of PDR is around 7%. But when you look at the duration of diabetes, the duration of diabetes has great implications on the proportion of people that will develop PDR. And as you can see, if the duration of diabetes is less than 10 years, the frequency of developing PDR is 1%, whereas if it's over 20 years, it was 32%. So that might have influenced also the result of the studies that I showed you here conducted in Africa, depending on the duration of disease in the participants that were investigated. With regards to risk factors, we looked at the evidence carefully in a prognosis review, which we undertook under the auspices of Cochrane. And for those of you that are not familiar with Cochrane library, I would advise you to have a look at this. This is a great source for evidence. So if you go to the Cochrane, you can see evidence on interventions and in different diseases, but also now, this was actually the first prognosis review that was supported by Cochrane, but the Cochrane Eye and Vision group. And so what we saw is that the evidence that was available disclosed that the main two risk factors for development specifically of PDR were high HbA1c and a higher stage of retinopathy. So you see that if you see patients with high HbA1 levels and people that have moderate or more severe stages of disease, you have to be very careful with them because they might actually go into developing proliferative diabetic retinopathy soon. And also there was some evidence suggesting that those people that have kidney disease may also have an increased risk of developing PDR. With regards to prevention, I would like to just draw to your attention a drug that is very inexpensive, that is called fenofibrate. And fenofibrate is what we call a PPAR alpha agonist. And it's interesting because if you knock down this PPAR alpha gene in animals, they develop all the features that we see in people with diabetic retinopathy. So they develop vascular leakage, leukostasis, pericyte loss and capillary degeneration, and inflammation, which is exactly what we see in diabetes. And then interventional studies that have been done in animal models of diabetic retinopathy have shown that fenofibrate protects endothelial cells and pericytes from apoptosis. Apoptosis means just cell death. There's the increased vascular permeability that we see in these animal models is improved after the animals are given fenofibrate. And fenofibrate, we know, blocks HIF-1 alpha, and that's a major driver of the increased VEGF, which is a major growth factor, although not the only one, that is involved in the occurrence of PDR and is released in areas of retinal ischemia. So there's evidence, again, we conducted this interventional Cochrane review in which we show that there's evidence suggesting that in people that have some retinopathy, that's what we call overt retinopathy, retinopathy that you can see in a fundus image, or retinopathy that you can see when you look at the back of the eye. In these people, there was the suggestion that fenofibrate reduced the risk of progression to PDR and also of need for treatment for PDR. However, the studies that were included in this systematic review were 2, FIELD and ACCORD. And these studies had as primary outcome cardiovascular complications, not retinopathy. But now there's studies ongoing looking specifically at retinopathy, so soon enough we will have a good indication whether you should use this treatment. I can tell you now that the treatment is licensed in Australia, Indonesia, Malaysia, and some other countries for the treatment specifically of diabetic retinopathy. But in general, it's used to treat hypertriglyceridemia. How about treatment for PDR? What is very important when we look at PDR to determine what is the risk of a patient that has PDR. And that depends on what is the degree of PDR. So it's different to have a little set of new vessels here or there in the back of your eye than to have what we call high-risk characteristics proliferative diabetic retinopathy, which basically I'm showing in these photographs, although I think that there's a lot of light, so probably you cannot see the images very well, unfortunately. But you can see if you have very large new vessels in the disc, or if you have any size of new vessels in the disc or elsewhere with preretinal hemorrhage, like the image in the middle is showing, or with vitreous hemorrhage. Those patients are at very high risk of visual loss, and those patients require treatment immediately. And what are the treatments that we have specifically for PDR? Where, of course, we talked about the risk factors, and those you need to control, controlling HbA1c, controlling, if possible, kidney disease. And then we have the laser, panretinal photocoagulation, PRP. We have anti-VEGFs for PDR, and I'll talk very briefly about that, and surgery. So there's a clear benefit that panretinal photocoagulation will reduce the risk of visual loss by half. And that was shown in a very it was done long time ago by the DRS and the ETDRS studies in the United States. And it's very clear that PRP should be done, as I mentioned, in people with high-risk characteristics, proliferative diabetic retinopathy, and you might consider it also before high-risk characteristics develop in people that might be at higher risk. How does it work? Well, laser, we know, destroys areas of retina. It actually ablates the outer retina, the photoreceptors and the retinal pigment epithelium. By doing so, also destroys the retina that is ischemic. So then, I was telling you how the ischemic retina produces VEGF, that is gonna then lead to the neovascularization. So if we reduce that drive, we reduce the area of ischemia by treating it with a laser, we'll reduce the drive, we'll reduce VEGF levels, and the new vessels will regress. It also allows, by killing those photoreceptor cells outside the macula, to have more oxygen that will go into the macula, which will be helpful. How is it done? Well, or how do I do it? We have several parameters that we control, like power. So you want to have a white, quite white spot, gray white, but not very mild spot. You want, usually we do it like by the ETRS, using 0.1 second duration, and I'm going to refer to this in a second. I usually use a spot size of 200 microns, whereas people in the ETRS, they were suggesting 500 microns, a larger spot size. If you do a smaller spot size, you can focus in them better, so you get better take in your retina, but you need to do more. And you space them like about 1.5 or about 1 burn apart, half a burn or 1 burn apart. And you cover all the mid-peripheral retina. And I want to stress the importance of covering also the anterior retina. That is very important, especially when we need to go to this size with surgery. So this is an example of one of my PRPs. Again, it doesn't show very well with the light, but it's important to leave that space in between spots on the first time that you do laser, because the patients might respond very well to this treatment, and they have very good chance to keep their peripheral vision, because the retina in between spots will maintain vision. So this is a draw of caution for those of you that use multi-spot pattern laser. That corresponds, for instance, to the Pascal laser. These lasers have the most 0.05 duration of the spot, rather than the 0.1 second duration that I was referring to you before. So they are shorter pulses. And the problem is that they are not as effective. So you need to increase your power much more to get the same effect. And sometimes patients have pain, and then you need to put anesthetic to cover that pain. But there's the evidence from a postdoc analysis from the DRCR network that shows that with multi-spot pattern laser, the patients had more worsening and progression of the PDR, and we showed the same thing in our own unit in Belfast. And I can show you just two pictures. The top one has the standard laser with longer duration of laser, 0.1. The one in below is one of the pattern laser typical treatments that you get, and you get minimal scarring in your retina, minimal dropout of retinal pigment epithelium and photoreceptors. If I show you, and I know some of you have autofluorescence imaging here, you can see the differential effect. You can see that up above 1, you can see how the pigment epithelium is gone, because the laser did what it's supposed to do, whereas the one below, you can see there's very minimal change. So it's not surprising that you're not getting the effect, and then these patients progress more. So this is a part of my own experience. Again, I don't have robust evidence to tell you about this, but these eyes also have less vitreous detachment. Usually one of the advantages of doing laser is that the vitreous detaches, which is good for the disease, because the disease stabilizes more after the vitreous is detached. And also if we need to do surgery, we will do surgery much better if the vitreous is detached. And doesn't seem to happen as much with the pattern laser. How about anti-VEGF for PDR? I can tell you that, again, there's been a review on this. I'm not going to expand, because anti-VEGFs is a very expensive treatment, as we were hearing before. And there's no really clear evidence that long-term they are going to be better. At the moment, we don't know. But we don't have the evidence, so we should continue with laser. How about complications of PDR and their treatment? So we have, with regards to vitreoretinal surgery now, we will go into eyes with proliferative diabetic retinopathy that have developed these complications, periretinal hemorrhage, when they are very large and cover the macula, if they are non-clearing vitreous hemorrhage, or if they are extensive membranes, and some of them, of course, are going to cause tractional retinal detachment. And in the surgery, it's essential that we understand the anatomy of the eye before going into the eye to know how these membranes are distorting the retina. Where are you? Because sometimes it's very difficult to discern what is retina and what is membrane. We need to preserve blood flow. Some of these eyes are very, very ischemic, and you don't want to compromise perfusion more. We can use preoperative anti-VEGFs to reduce the risk of bleeding during the surgery. We need to address whether, if patients are on anticoagulants, what to do with those, and then the time of the surgery. So I'm going to go through these aspects. Again, we have ultrasonography and we have OCT. And I usually encourage every vitreoretinal surgeon to use both, because each of them provide you different and complementary information. You can see very well the movement of the vitreous and areas of traction with the ultrasound, which I don't think that you can, certainly with the conventional OCTs that we use in clinic. And it allows us to sometimes even identify the pegs, which are the areas where the new vessels go from the retina into the membranes and into the vitreous. It allows us to differentiate tractional retinal detachments from tractional retinoschisis, which is important to know when you're doing the surgery. And I was talking to you about blood flow. If I have an eye that is very ischemic, I'm going to be very, very careful, because preoperatively, the drops that we use to dilate the eye and the anesthetic that we put to anesthetize the eye, both of them are actually vasoconstrictors, so they're going to compromise the flow. But also intraoperatively, because if we increase the pressure for a long time to make our blood vessels to stop bleeding, we're going to compromise that blood flow too. And the same thing postoperatively. So if postoperatively we have spikes of blood pressure, those equally can compromise the flow. So I'm very careful about this, and I think about this. Do I have evidence that I need to look after these things? No, but it makes sense, so I do it. How about the use of anti-VEGFs perioperatively, so before the surgery or intraoperatively? I like to use them before the surgery, and I'll tell you when, but basically there's very good evidence. Again, go to the Cochrane Library and you see this very excellent review, and it shows that you'll reduce your risk of postoperative bleedings. And even they show a reduced risk of retinal tears that we produce when doing the surgery. So I use it regularly before any of my traction retinal detachment surgeries. And when do I put it on? Well, there's, again, basic sciences evidence, but also clinical evidence that supports that the probably optimal time to inject them preoperatively is exactly a week, 5 to 7 days prior to the surgery. Then you get the maximal effect, making your blood vessels regress, and minimal risk of fibrosis and traction that could lead to traction retinal detachments or making worse if the retinal detachment is already present. How about anticoagulants? Well, I did a review on this topic very recently, and I can tell you that there's no robust evidence saying that you must stop them, but there's some evidence suggesting that people with diabetic retinopathy and proliferative diabetic retinopathy and PDR, it might be wise to consider why are they on anticoagulants or antiplatelets. Because if the risk of them stopping them is very small, maybe it's wise to do it so you get less intraoperative and postoperative hemorrhage. With regards to timing of surgery, again, this has been investigated in the past, and we have really only one robust trial, and that was the diabetic retinopathy vitrectomy study. And they show that you don't want to wait too long to operate on this size. And this is the bottom line. So they have shown the benefit of operating when you have moderate new vessels, which are presented. This is a slide, of course, from the paper which was published many years ago with examples of the type of fibrosis and proliferation that you have. And certainly it's much milder than what I'm going to show you now that we see in our patients, even in Belfast, in Northern Ireland. And it's the same thing from the timing of surgery if you have a patient with vitreous hemorrhage from diabetic retinopathy. There was the same trial looking into this, and it showed that basically you want to operate earlier, and certainly earlier than 1 year. I'm just going to kind of like take you to the last slides of my presentation. And this was a systematic review and meta-analysis that we undertook, looking at outcomes of our surgery for TDR, traction retinal detachment. And we saw that we are extremely good at fixing retinas. But on average, the visual acuity on patients operated with traction retinal detachment was not very good. And when we look into the reasons and we look at univariable and multivariable meta-analysis in these large meta-analysis, we found that there was only one factor that appeared to be significant, which was visual acuity at presentation. So you want to operate not too late in these eyes. And I'm just going to conclude by sharing with you one case. So this was a lady in her 20s with type 1 diabetes. You can see she presented with proliferative diabetic retinopathy, high-risk characteristics, preretinal hemorrhage, and quite a large extensive new vessels. So she was treated with pattern laser, and she progressed to what I'm showing you here. Massive proliferation, very marked, the fovea was off, macula was off, and then they refer her to me for surgery. So again, you don't want to get to this stage to refer it to the vitreoretinal surgeon because it's really difficult. But I think these eyes, always we should give them a chance because these patients have 2 eyes and often the second eye goes in the same way. So you want to get as much vision as you can. And if we could play the video, please, I'll show you what I usually do. So I have a few principles in my surgery. Is it possible to play the video, please? So I usually clear the blood and in these eyes first so that I have a best view possible. I use an illuminated peak, which is an instrument that gives me light but also is ROM, so that I can separate the membrane from the retina. These membranes are very adherent to the retina. The retina is detached, so it's very easy to make breaks in the retina. So I work liberating these membranes, separating them, and then cutting the pegs with the cutter, the pegs, those blood vessels that go into the membranes, or with scissors. And then what I tend to do is, this is what we call en-bloc dissection. So you're going to remove all the membranes even before you detach the vitreous, because the vitreous is pulling these membranes up for you, so it helps you. And then working quadrant, so I don't pull from away because these retinas are very ischemic, so they can break very easily. You have to be very, very careful. I tend not to use ever oil in eyes with diabetic retinopathy and proliferative disease and traction retinal attachments. I don't think it's a good thing. And so I'll just show you how she was. So miracles do happen. So she ended up having a little bit of cataract. You can see in the picture on the left. But then we removed the cataract. She had macular edema, treated the macular edema. She ended up with 6/9 vision. Macula off with thick membrane. So you need to fight for this because, again, coming back to good vision is still possible. And I'd like to thank you for your attention.
All right, if we can have our presenters come to the podium. And all I have to say about that set was, that was frightening. Eat or be eaten, TR repairs, all of that's very frightening to me. So anyways, thanks everyone for their great presentations, and we will take questions from the audience.
Thank you. Could I ask a question to Professor Chiku? Of course, you may know I'm a glaucoma specialist. I have the impression that glaucoma is way behind in applications of AI, and we would like to take advantage of that. Why do you think is that? Why we are years behind, if that's your same impression? And my second question is, some members of the public are afraid of AI, and there is a lot of concerns about they don't understand, they are worried, So how we could overcome these these barriers from the, members of the public? Thank you.
Thank you for the question. I think glaucoma is behind even with non-artificial intelligence because it's just such a difficult disease to understand and to give definite answers. However, it is becoming more included. So the system I showed with the nice-looking camera actually does screening for AMD, DR, and glaucoma at the same time. Our experience with the project we did in Kigali was the algorithms are not very good at reading nerves from different races. So when we started screening for diabetic retinopathy, I said, why doesn't it look at other things? I don't want to tell my diabetic patients, you're fine, and actually they have a cup disc ratio of 0.9 because they believe me. If I say you're fine, you're fine. So I need the algorithm to at least say, you're fine with diabetes, but something is wrong with your optic nerve. And I was lucky because I had access to the writer of the AI program, and I said, I will not accept to use it if it doesn't do the disc. And so they incorporated that. And the first version was rubbish. Every African had glaucoma. And they had to teach it to read African discs because the peripapillary pigmentation was very confusing to the algorithm. So I think those are some of the reasons. Glaucoma is just difficult, even in real life, that but I think it will get there. It will get there. I think reading the cup disc ratio will be sorted out and has probably been sorted out. Yeah. With the second question, I think as human beings, we always fear what we don't know. And I think the AI industry itself is adding to that fear that we have with all these examples and description every time something goes wrong. And it's the same thing when mobile phones came and we all knew we are getting brain cancer within 1 year. So I think it's normal for the level of development where we are, but the public is pretty quick to get switched on, and I think part of the fear also is they don't realize they're already using AI a lot. When you're on Facebook and it tags your friends, what's that? It's because it can identify their faces from your Facebook pictures. So I think the public will catch up probably quicker than ophthalmologists. Yeah.
Next question.
Thank you very much. My question goes to Dr. Levine. Thank you for a good presentation about your management of macular edema in diabetics. My question is about Avastin availability. So you did a good number of patients, but is Avastin today Rwanda FDA approved in ophthalmology use? If yes, who is the supplier today? If not, how can we speed up the process to have it registered, approved, and available on the market? Thank you.
Thank you, Professor. So Avastin is available in Rwanda, and some pharmaceutical companies can sell it. Previously, it was very difficult. Some used to go abroad and bring it just in their pockets, but now they can be gotten in Kigali. About the approval from FDA, I'm not sure if it is approved because Avastin is used as off-label medication, which is a concern. Maybe if there is someone who has information about the approval, but I have not just heard someone saying it is approved in Rwanda. No, it's not in ophthalmology. Yeah. So that's why other approved anti-VEGF are needed to be used for the safety and efficacy of our patients.
Thank you. Sorry, if I may chip in here too, if I'm allowed. So I think that you need to really be, of course, always careful about the using of licensed medications. But there is a good reason for Avastin not to be licensed, and the main reason was that the same company spent a lot of money developing a drug that was specifically for the eye. But Avastin has been, and then of course they want you to use that because they want to get the money back. So as simple as that, as I see it. But you know, the reality is that there's been a huge number of studies comparing Avastin with the other anti-VEGFs, which are terribly expensive, and not for just Africa, but for the rest of the world. And we are actually throwing out millions when probably that money could go into treating diseases timely that might save much more sight than the difference that it will make to see a patient treated with Avastin than treating with one of the other anti-VEGFs. Maybe you will change, 3, 4 letters or 5 letters, and that is not a change that is so clinically relevant for your daily life. Not only that, I can tell you that from the people from the GMC in the UK, and this is the General Medical Council that looks after the safety and protects patients. I had a conversation with them, and they were saying, well, if you have a drug and you can see that there would be a benefit to the patient, it might be justifiable to use a non-licensed drug because the gain for the patients is going to be much larger. And probably that would be the case, of course, using an anti-VEGF that is Avastin here than using a very expensive drug because you will be able to treat many more people. And with regards to the off-license use of drugs, we use them all the time. We use it to treat endophthalmitis all the time. So in my opinion, I think that you're very wise using Avastin here. And I would wish I could use it in the UK where I work because we'll save a lot of money and we'll treat more patients and we'll save more sight.
Okay, thank you. My question goes to Professor Shiku. For some of us, we are still very new and very young in this career of ophthalmology. Sometimes when we examine patients, we found that there is a contradiction between our clinical findings and the results of the investigations. And in some cases, we have to go to treat the patients based on the results of the clinical findings. Now, artificial intelligence has come and we hear that if we don't eat it, it is going to eat us. I'm just asking for advice. How confident should we be and trust our clinical findings to treat our patients when there is such a contradiction?
I didn't see where the question is coming from. I'd like to see who's asking the question. Yeah. Okay, I see you now. That's a difficult question, and I would like to invite anybody who can contribute to please assist me. I think it's very difficult in life to be 100% confident with anything, and what we do is we use our best judgment and we use the evidence that we have, and we make the decision we think will be best for the patient. How I like to look at artificial intelligence is that it's another tool that we can use to assist us to reach that decision. So yes, you have the fundus photo, it helps you. You have your own knowledge, it helps you. And now you have another tool that you add. And together you put everything, and as a clinician, then you make the best decision for your patient. So rather than thinking of it as adding to the confusion, I think it's adding an extra tool that can guide your decision. But I invite anyone else to add to that question.
All right, I've got good news and I've got bad news. Lunch won't be ready till 12:30. That's the bad news. Good news is we can take a few more questions. All right, we'll go right here next and then there.
Okay, thank you. Yes, so back home in Uganda, we actually use Avastin for a number of reasons that have been mentioned. It's cheap, and for many of our patients, that's all afford. They won't be able to afford the Lucentis, so Avastin is the way to go for us. So my question is about the management of chronic macular edema. Dr. Levin, what is your experience in managing patients with chronic macular edema? Because many times we get patients who are going to get even more than 6 injections of Avastin, and there is completely no improvement. And then also laser is not readily available in all centers. So you might find that Avastin is the other anti-VEGFs is the only. So how many cycles of maybe anti-VEGF would you give and then be like, okay, I think this is the maximum I can do for this patient?
Thank you for a good question. Yes, Avastin is cheap and readily available more than any other anti-VEGF in our settings. But the Avastin needs to be injected maybe every 4 weeks, and sometimes you may go up to 8, 10 injections, and the edema is still there. Sometimes when you go, let's say we inject enough Avastin, then we see edema is not resolving. We consider also intravitreal triamcinolone, which is another we use. Then we may shift back to Avastin, but in most of cases, the edema will resolve. But in terms of visual outcome, there is not much change. So we are lucky we have Avastin and laser in our hospital. So sometimes also we consider laser, but the problem comes when we have edema which is involving the central fovea, where if we're going to want that fovea, that's a problem. But if it is a bit out of the fovea, we also consider using focal or grid laser.
Would you mind if I also make a comment? Thank you very much. So just to make a comment about the treatment for macular edema with laser. So laser treatment was shown to reduce risk of visual loss by the ATRS. And indeed, it's a very, very good treatment. And of course, if you are lucky and you have the ability to do fluorescein angiography in your units, I would advise you that it's very wise to do it before you start treatment. In many of these cases that have central fluid, the point of leak is not central. It's away from the fovea. But the fluid has been tracking down because it's a chronic disease. And then it reaches the center. So you treat your area of leakage, which is farther away from the fovea, and your patient will dry. And if you treat with laser, you're going to dry many patients, and you can say goodbye to the macular edema, because rarely, it does happen still, it might come back, and that's the problem, recurrence. But if it comes back after laser, usually it comes back in fewer patients and less times. Whereas anti-VEGFs, as you know, in the majority of people, you stop them and the fluid will come back sooner or later. So I think that macular laser is an absolutely great treatment, but because there's been such a push with anti-VEGFs, people tend to forget about it. Even, there's interest so that people will forget about it because, of course, it's a big market. Billions, moving billions every year in every country. So my advice is, before you start, maybe consider doing an angiogram, even if you don't have the angiogram, if you have an OCT, or if you are a good clinician. And I was very happy to hear the professor talking about teaching of indirect ophthalmoscopy, and I hope that you don't stop doing it even with AI, because if you're a good clinician, you can actually put a lens in the retina, in the cornea, and with a contact lens, you'll be able to see the thickness of the macula so well. You don't need an OCT really. So you then see the idea of thickening, you likely see microaneurysms there, and you can treat with laser. And I can tell you that many patients will do very, very well. So, and then even if a third of patients do well, you have one-third less patients to inject every month.
John, if you don't mind, I can also contribute to that question.
Please.
Someone asked me the other day, how much do you follow what the trials say, all these trials that Dr. Levine mentioned? And I said the trials are really good because they give us where to start and give us the evidence to defend what we do. But the truth is, in our region, we then customize that almost from day one. And I guess also elsewhere, they're finding that patients don't behave like they behave in these clinical trials. And one of the things that in my medical retina practice I do is I use laser a lot. And I use it because exactly what you're saying, it works, but it's cheap, and it's a once and done treatment most of the time. So in terms of the combination with injections, with triamcinolone, laser is always part of that equation, much more than what is recommended in any trial. And I just find that that formula works. And our big problem, again, in the continent is we don't document what we are doing. If Pete and Michael were all recording, because I'm sure you're also customizing your treatments like that, if you are all documenting and publishing, perhaps we would have some African protocol that is not saying the trials are wrong, but is saying once you have the trial result, now where you don't have this, where you don't have this, you could modify like this. I think that's how we work. So yeah, if you just combine with what you have. And
yeah, okay, sorry. I just want to make also a comment about the trials, because just to remind you, when you look carefully at these trials, you will see that the trials that compare anti-VEGFs with macular laser had very thick retinas, well over 400 microns, very thick retinas. The majority of patients, those patients that enter into these trials were with that category. We know that, of course, if you have extremely thick retina, there is less chance that the laser is going to work. But again, the trials are favoring already anti-VEGFs because most of the patients have very thickened retinas, where we knew, as clinicians, those are the ones that are going to respond less well to the laser. Of course, you could say, well, let's do injections, lower the thickness of the retina, and then treat with laser. And exactly that is what we're going to be doing in the UK, a study that Michael had just mentioned that we're going to embark on, for which we have a grant from the government to undertake this DAME study. So hopefully that will answer this question. We might be able to start with anti-VEGFs in those that have very thickened retinas and then continue with laser. This is not what it was done in the trials comparing anti-VEGFs with macular laser. So hopefully we'll have the answer. But if you have patients that have retinas that are not very thickened, go for the laser, please.
Hello. Very good presentations by all of the panelists. My question is, there was a randomized controlled trial published June 2023 that showed a VEGF-CD inhibitor for neovascular age-related macular degeneration in combination with VEGF-A inhibitor, it showed promising results. Do you think it can be used with the management of proliferative diabetic retinopathy or diabetic macular edema, the VEGF-C and D inhibitors combo with VEGF-A inhibitor?
Is there a question for me? Okay. I would say that the likelihood is that the company that is producing the molecule that is investigating its AMD, I'm sure they will have trials already prepared following on maybe vein occlusion, even diabetes, because that's how they usually do it. So, you know, they will trial that drug in other conditions that are similar, as you see that it happened with the other anti-VEGFs. Whether or not it's going to be more successful than others, we will see. We'll have to wait and see. Thank you for the question.
All right, this side. Are we all sleeping on this side? All the questions are coming from over here. I don't know what's going on this side. Any questions on this side? No. All right, we'll open it back up to this side.
Thank you. My name is Lilian Ngawire. I'm an OCO at University Teaching Hospital at Butare. My question goes to Dr. Chiku. Recently, we have started a research on diabetic retinopathy, about the prevalence of diabetic retinopathy among patients who are treated in our hospital, about 400 patients. When we started this study, we were obliged to purchase the fundus camera, and we found that it was very expensive, about 10,000 Rwandan dollars. So we found that it eases our task to examine patient and have pose the diagnosis. So I would like to ask, what's your plan, as I think you are at the highest position, on the availability of those fundus cameras equipment in our country, so that we may avail them in a different hospital and train OCOs to use those cameras, and in collaboration with the ophthalmologists. The second question goes to Professor Naomi. You talked about the fenofibrate drugs as in the prevention of diabetic retinopathy. Is it allowed to start it at the early stage of diabetic retinopathy? And what's its availability on?
Bring quite a large number of cameras into Rwanda. I think the main problem is whose response don't have that capacity. So I think there's a role for policymakers and FDAs and those kind of people to assist us so that we can get these things into the country.
All right, thanks, panelists. You want to add? No. Okay, I think yes. All right, we'll take one last question.
No, there was already, John, sorry. There was a question about fenofibrate.
Yes,
and I must apologize because I don't know whether you can get fenofibrate here to treat people with hypertriglyceridemia, which is the indication. If you use it for retinopathy here, I think that you would be using it off license. Again, and if you use it, you would need to think on whom. And again, if you had very mild retinopathy and your patient is in the 50s or 60s, and there's no major other risk factors that you would think this patient is going to develop bad disease, maybe that's not the patient that you might think about using it. But if you had younger people with moderate retinopathy, that would be, and even high HbA1c levels, then that would be an appropriate thing to use. But you will need to talk to the doctors that look after these patients. We tend to do it with the general practitioners. Certainly when I ask in UK for anybody to start on fenofibrate, I usually do it in conjunction with the general practitioner. Thank you.
All right, thanks to our panelists. That was fantastic. And a few announcements coming for our MC.
Yes, another round of applause to our panelists, to our chairs of this session. They really did a great work. I think we learned one or two things, and I can see we kind of low on energy, and that's the time we need to go and put in some fuel, right? Because we still have 3 sessions coming up, and I would like to take this opportunity to let you know that there is an exhibition going outside. The state lunch will be ready at 12:30. Maybe you can use these 5 minutes to step out and then start, touring the exhibition space there. The protocol team will be there. They will guide us once the lunch is ready. So we can use this opportunity to check on the exhibition. Otherwise, lunch, we will have to be back in the room at 1:30. Please keep time, as you see that we have a very huge agenda ahead. So I thank you all for your kind attention this morning session, and please follow the protocol team to the exhibition center. Thank you so much.
In Portugal, and she did her training in Scotland, in Glasgow, and she also completed her PhD in Glasgow. From Scotland, she went all the way to Australia and did her retinal training at Flinders in Adelaide, and then came back to train for further training at Liverpool and Moorfields Hospital in London. Dr. Teresa is currently the research lead for BEVAS, which is the British Vitreoretinal Society for the VR surgeons. And she has an interest on the vitreoretinal interface, which is the source of problems for a lot of VR conditions. She has worked in various countries across Central America, Africa, and China. So I hope you will welcome Dr. Teresa to start her talk. Thank you.
Thanks for the introduction. It's a pleasure to be here at this meeting, and I have to congratulate the team, Dr. Theophile, Dr. Michael, and all the team. So also I have to congratulate colleagues like the ophthalmic practitioners, and there are a lot of you here, and I know you contribute a lot to the success of ophthalmology in Rwanda. So I was asked to give a talk on a dive into VR surgery to non-specialists. It's going to be a shallow dive because I'll go through the commonest conditions we see in a vitreoretina clinic. So I'll be talking about the following conditions here, starting with posterior vitreous detachment that we all see, specialists, non-specialists. And although the majority are uncomplicated, it is important to note the ones that are complicated and you might need to refer to the vitreoretina clinic. And they are complicated. They are complicated because of the strong focal attachment of the vitreous to various parts of the retina, leading to vitreous hemorrhage, retina tears, or rhegmatogenous retina detachment. I think it's important for all of us to remember what are the high-risk patients that might develop tears and subsequently retina detachment, like high myopes. High myopes are defined as patients with a refractive error of more than -6 diopters and axial length longer than 26 millimeters mercury. Aphakics, patients who've had a recent cataract operation. Diabetics with new vessels membranes, as you know, if they start developing a PVD, they are at risk of vitreous hemorrhage and tractional retina detachment. If there's a history of tears and retina detachment in the contralateral eye, you have to be careful when you examine a patient with a fresh PVD, and of course a history of trauma in that eye. It's important to remind everyone that PVD increases with age, and it's about 87% in an age group of 80 to 89 years of age. So I'm not going to dwell too much on complicated PVD. What is important to remember is that there will be patients who will develop tears. 8 to 15% of acute PVD will have retina tears. And of course, retina tears can lead to retina detachment. So fresh PVD need to be, have a good examination. The referral guidelines, I'm going to move on from here, but of course, if there are high-risk patients, this is for, of course, non-specialists and ophthalmic practitioners. High-risk patients, you're not confident, you should refer to a VR clinic. So now going through holes and tears, I think this slide is perhaps helpful to you in that when we start examining the retina, it's important to know that the superior temporal quadrant is the one that you will find the majority of retina tears. So rather than starting temporal, nasal, or inferior, do concentrate in examining very well the superior temporal quadrant, because that's where you'll find the majority of tears. I'll just mention the trophic holes that we all come across, and often during examination for another presentation or another symptom, and the majority do not require treatment unless they are present in high myopes or patients with high risk. Of course, if there is subclinical retina detachment, these patients can develop a retina detachment, so you would want to do laser, or if not possible in your department, you would want to refer to the nearest department for examination and treatment. It's also important, as we've been mentioning throughout today, to take a good history, do a good examination, and ascertain the risk factors. We all find peripheral retina degeneration and peripheral retina lesions, and they are all very difficult to differentiate because they all look much the same. And I think what I would say to you is to remember that lattice and snail track are the ones that are potentially causing risk for retina tears and retina detachment. And lattice and snail track is not uncommon. It's about 10% in the population out there. They don't develop retina detachments, only a variation of lattice is snail track. You do not have pigment, and it's very common in the African population. So these two degenerative changes in the peripheral retina are risk for tears and retina detachment. And then you have a list of names and changes that, as I said, usually do not lead to any detachment or holes. Operculated tears, we do find these operculated tears that unless in high-risk patients and associated with retina detachment, we don't necessarily treat because there's no localized traction, and the operculum, so it's part of the retina that has come off, and there is no traction, and the operculum tends to shrink, and the majority of patients do not require treatment. This is different from an operculated horseshoe tear. You know, this is a more liquid, and it's easy to penetrate the tear or the hole. And of course, then you have a building up of fluid between the neuroretina and the retina pigment epithelium. And at the bottom of the slide, you've got the risk factors for patients, which ones are the high risk to develop rhegmatogenous retina detachment. Of course, as you know, there are other types of detachment that are important to know, and they need also to be referred urgently, but not as urgent as rhegmatogenous retina detachment, because we want to preserve as much as possible the macula. And if patients present with MAC-off for more than a week or twists, doing OCTs in almost every patient that attend macular holes. And why do we have that? We have this because it's an aging pathology, the separation from the vitreous from the macula, which is a strong adhesion. When it's not done evenly, it can distort the macula. Here, you have the vitreous starting to separate from the central fovea, but is not distorting the architecture of the macula, and it's called a vitreomacular adhesion. When it starts distorting and causing changes in the architecture, here we talk about a vitreomacular traction. And patients presenting with vitreomacular traction, they will have blurred vision, distortion, and we would offer vitrectomy in these patients. So when you've got this separation from the vitreous, from the macula, usually there is some form of epiretina membrane, so residual posterior hyaloid left. And when it is not causing changes in the shape, in the architecture of the macula, we call cellophane maculopathy. When it progresses to a more advanced stage where the macula is contracted, we call it macula pucker, and that causes symptoms of distortion, blurriness, changes in size of objects between the two eyes, and it can affect the patient's quality of vision and life quite markedly. So to help surgeons and the referring doctor and optometrist to understand, there has been a classification that now is used, and the idea is that stage 1 on top of this slide, you see the fovea is preserved, and stage 4 where all the layers of the retina are distorted, and this helps to indicate to the patient the prognosis for recovery of vision, because a patient with stage 1 will have a better outcome. But so there are also, this is not so straightforward, but I don't have time to go into a lot of detail, but I think this is important to know there are these different stages. So you will have seen this kind of patients with vitreomacular traction and associated epiretina membrane and intraretinal cysts. Royal College of Ophthalmologists, because of the reason I've just said, we need to try to reassure colleagues, not only optometrists, but colleagues, when to refer patients to our clinics. And this is on the Royal College website, if you want to read in more detail. But basically, the recommendation is that patients that are symptomatic, we would see the patient in our VR clinic, and then we would have the conversation, yes or no, to operate. If we don't operate, we don't keep monitoring in the clinic, we refer back to the optometrist. In terms of patients asymptomatic, if a patient at the examination by the optician, it was noted a drop in vision, 2 lines or more compared to the baseline presentation when they presented 2 years before, and the fovea is involved. So remember, it's important to look at the central fovea to see if there is changes in the structure of the macula. We would want to see the patient and again have the conversation, yes or no, surgery is indicated. So now we've talked about vitreomacular traction. Vitreomacular traction, if it's progressing, it can lead to a macular hole. And this is a definition of a macular hole. This is clinically what it looks like. Before the OCT coming along, we would see these patients in the fundus photographs and on examination, and we would see there was a hole. In this case, not a small hole, so this would be stage 3 at least. And gas classification is still used despite being now for so many years, and it takes into account the status of the vitreous and the size of the hole. So we have stage 1, 2, 3, 4. And on top of this, and with the OCT allowed better characterization of macular holes, because now we can see exactly what's happening between the vitreous and the macula. And what to remember is that stage 2 holes usually have vitreomacular traction. And stage 2, of course, are the smaller holes, and they would do better if we were operating on them earlier. Stage 3, you see on the right-hand side of the slide, you have this operculum of the retina. So you have completely release of the vitreous at the macula, but you can't assume it's released from the optic disc, because usually it's not. Females with this condition are not doing so well. Unfortunately, it happens mainly in females. And one interesting point is that patients will ask you what is the risk of developing a macular hole in the other eye. And I think if you remember that, it's about 10% after 5 years. Okay, so particularly if they have vitreomacular traction in the fellow eye. And so I'm nearly finished. I have 2 minutes to go. Thank you. As I said, if we're going to try to operate and give the best outcome possible, would be the smaller holes, because this is the holes that are at risk of progressing. And I'd like to thank the team. Thank you very much for listening. And I also would like to say that Michael is doing macular hole surgery in patients late presentation, and it's interesting that he's noticing that patients themselves notice improvement in vision or in quality of their life. Whether it's real because we're doing something or not, it's to be seen, but it's interesting. Thank you.
Yeah, thank you very much for the nice presentation. Yeah, let me introduce the second speaker. The second speaker for this afternoon is Dr. Piet Noe, who is a senior consultant ophthalmologist and a vitreoretina surgeon. He is also a co-founder of Rwanda Charity Eye Hospital, where he serves as a medical director. He's an ophthalmologist, but with different subspecialties. And also, he has big experience to work in Africa. 3 years in Uganda, 9 years here at Kabgayi, now 5 years at the Charity Rwanda Eye Hospital. Dr. Pitt, welcome.
Thank you very much. Thank you, Dr. Theophile. Thank you, Dr. Michael, for this kind invitation. It's a very nice conference. I'm very happy to be back in Kabgayi. And I was asked to give a short talk about the importance of early vitrectomy in open globe injury. Next. So I speak about open globe injury because for closed globe injury, it's not so urgent to do a vitrectomy. So we have globe ruptures, globe lacerations, penetrating injury, perforating injury, and intraocular foreign bodies. This all fall under open globe injury. We see it all the day. When I was working in Kabgayi, I was not yet in the first years, I was not yet a VR surgeon, so I was most of our colleagues in Rwanda, we are all anterior segment surgeons, and we all get so many cases of corneal scleral lacerations. We are happy when we repair it nicely, our sutures are okay. We remove most of the lens, we try to keep some posterior capsule left, and in the best case, if you have an anterior vitrectomy machine, you do some vitrectomy, anterior vitrectomy. But my experience was in Kabgayi, before I was VR surgeon, that 1 month later, most of those patients came with a very low pressure, phthisis, and the eyes eventually end up in evisceration. So what happens in the back of the eye when you have a corneal scleral laceration? The vitreous is incarcerated very often in the scleral wound or in the corneal wound, and there is traction from the vitreous on the peripheral anterior vitreous, which is pulled anteriorly. And there is also PVR growing or membranes growing on top of the retina. This gives also traction, so the whole retina will be detached because of traction. So there is also the blood retina barrier is disturbed, and there are all types of inflammatory cells which come in the posterior segment. There are fibroblasts, glia cells, and all types of inflammatory cells which start to produce cytokines and inflammatory products. And in the end, you get a membrane on your retina which will contract. And the aim of early vitrectomy within the first week of surgery, of trauma, is to remove all those substances from the posterior segment, from the eye. So blood, lens, remnants, they all contribute to this serious inflammatory reaction, which gives, in the end, a contractile membrane on top of the retina. So Ferenc Kuhn is like the Pope for eye trauma. He advises to do the vitrectomy within 100 hours. It is 4 days. So we try to do the vitrectomies at our place within the first week after we sutured the sclera and the cornea. But there are some reasons to delay a little bit when the cornea is too edematous, when there's too much blood under the retina or in the massive choroidal hemorrhages, or if you did not succeed to suture the complete sclera up to the posterior end. So there are many other options. One is the iris clow lens, which was invented by Borst, and which is a perfect solution if you put it retropupillary. And the problem is that it needs a big incision, so you create some astigmatism, and there is no foldable iris clow lens. But nowadays there's another solution. There are scleral fixated lenses. We do the Yamane technique, and we can do it with a 3-piece IOL from Aurolab, which is available in all our hospitals. It's a hydrophobic IOL, so that's also an advantage. And I show a short video from 2 days ago at our hospital. So you have to externalize the 2 Prolene haptics, and you do it via a 27 gauge needle, which you insert at 2 millimeters from the limbus. So it's a bit faster than in reality. So you do it with 2 hands, the handshake technique. You use a 23 gauge forceps. But important to say is that it is used after a complete vitrectomy. You cannot do this without a complete posterior vitrectomy. Otherwise, you are pulling too much on the vitreous. So one haptic is in place. Now at 180 degrees, we do the other haptic. So this was not an open globe injury, it was a closed globe injury. And the advantage is that you just need 3 millimeters incision. So this is a better solution than the AC IOL. Another solution is the Carlevale IOL, which is a new IOL invented in Italy. It has haptics which end on a T, and the T is also brought out of the sclera, and you make a scleral flaps, and you bury this T under the scleral flaps. But now it is a bit expensive, this Carlevale IOL, and it's a big problem for our settings. But now there's an Indian Carlevale IOL on the market from Apasami, which is very affordable. It's a hydrophilic IOL, which we also use. This is, you make 2 scleral flaps, and you make the incision, or you make a stab incision of 23 gauge at 2 millimeters from the limbus, and then you take one of those teeth, and then you, at the other side also you take the haptic, and you bring it outwards. So this was an open globe injury. So if you do this, if you remove the lens completely, if you have, after 1 week, a complete vitrectomy, you will not end up with eyes with low pressure, but you will end up with eyes with very high pressure. So all of them eventually get glaucoma. And in our setting, we do the first surgery is corneal scleral repair. Then we do, together with a lensectomy and an anterior vitrectomy. Then 1 week later, we do the complete vitrectomy. And third surgery is to remove all the sutures from the cornea, and we do it together with the scleral fixated IOL. And then eventually people get an ADI tube, which is a glaucoma drainage tube, which is very affordable also for us. And with all those interventions, 4 interventions, you can save some eyes. So as a conclusion, I would say as anterior segment surgeons, we see only the tip of the iceberg in open globe injuries, and we have to look a little bit farther. Now that also in Rwanda there are more VR surgeons, I think it's time to plan a quick vitrectomy. I don't see any more the slides, but it's okay. So another takeaway message is that you should remove the complete lens in open globe injury if the lens is damaged, is severely damaged. If you have a complete posterior capsule, it's okay. And also another message is not to use the AC IOLs. There are much better solutions nowadays available also in Rwanda. Thank you.
Thank you, Dr. Pete. Stay on the stage. Dr. Teresa, do you like to come to the stage? You can take questions. Does anybody have any questions to begin with? Maybe I can start, ask a question for both of you actually. You're both experienced VR surgeons, but maybe the majority of people here do anterior segment surgery, cataract surgery, and occasionally bust the posterior capsule, get vitreous loss. What tips do you have for the situation where they have vitreous loss in dealing with vitreous loss during cataract surgery?
Yeah, I think the most important thing is to not do cataract surgery if there's no anterior vitrectomy machine available. And unfortunately, this is the case for most of the surgeons in Rwanda. So if any NGO representative is here, I think very important to distribute vitrectomy machines, anterior vitrectomy machines.
There is I've used it elsewhere in Africa. There is a handheld vitrectomy machine called an Intrector, which is battery operated. And if you don't have a vitrectomy machine with your phaco setup or with your cataract surgery, I've done camps elsewhere in Africa, and we've just done manual surgery. And it's called an Intrector, and just takes you out of trouble. It's a handheld battery-operated device, and it's fantastic to do a good anterior vitrectomy. So maybe if you don't have that, you can consider using that.
I just would like to say that if there's a complication, complications happen. And rather than trying to do something yourself, just refer, because the patient can have a good outcome from a complicated situation.
That's a good point, actually. If you feel that you're in trouble, there's no harm in leaving it and referring on, even in this situation, because they'll end up with a better prognosis afterwards, where in a department which does have equipment. Any other questions?
Thank you. Not sure. It works now. Yes. Thank you very much to both. Could I ask Dr. Pitt, would you consider any treatment when you have open globes, such as steroids, or systemic steroids, or local steroids? Could you give us advice on that regard, please?
Yes, we give Kinacor to all our patients afterwards, Subtenon, but we also give antibiotics post-op. So we give intravitreous antibiotics.
But
we don't give systemic steroids, but
We don't see much trauma in UK, so you are the expert on that.
If there are no questions, we can conclude. Is there one question there? No? Yes?
One question for Dr. Pitt. Thank you very much. So in cases of trauma, many times we see patients coming with maybe a corneal laceration, and then they have an early forming cataract. Many ophthalmologists would maybe choose to first leave the cataract and they only do the corneal repair, leave the cataract, and maybe plan to do surgery later on. So what would be your thought about that? Would you consider doing the repair, remove the cataract, such that you have an opportunity to do the early vitrectomy, or you would choose to leave the cataract first? Thank you.
it depends a bit if the anterior capsule is broken. If there's a tear of the anterior capsule, I would remove the cataract. And if the posterior capsule is intact, I would leave it. But very often with lacerations, you have the foreign body went inside the eye through the cornea in the lens, through the vitreous. And in that case, I remove the complete lens. So you don't leave posterior capsule. But if you have just an anterior opening in your capsule, I remove the cataract, I leave the posterior capsule. And I do it in the same session as the laceration repair, as the suturing. Because as you know, if you leave the damaged lens with an open anterior capsule, this gives a lot of PVR, this gives a lot of inflammation.
I just wanted to ask you, so if you have a situation of retina detachment, in a case of trauma, you have a higher risk of PVR. Did you say you remove the posterior capsule as well? Because then it contracts and you don't want the posterior capsule there. Yeah.
Great. Thank you to both our colleagues. Join me thanking them.
Thank you so much to our presenters, and thanks to Dr. Theophile and Nilau for moderating this session. The next session is going to be moderated by Professor Chiku and Professor Naomi. I give them the floor to introduce your panelists. Thank you.
Thank you. So our first speaker is Dr. Jan Vicaria from Adam Brooks Hospital, Cambridge, and the presentation is also from Kabgayi unit. It's a case of ocular cysticercosis, management, and a literature review. Thank you.
Okay, hello everybody. So I'm Jan V, I'm from Cambridge in the UK. In this presentation, we would like to share with you a case of an intravitreal lesion in the vitreous cavity of a young female. And I'd like to share my thanks with Dr. Michael for sharing this case with us today. So we had a 42-year-old female who presented with decreased vision in her right eye for the last 2 months. Her vision was recorded as 660 in her right eye. posterior segment examination revealed the presence of vitritis. There was also a translucent yellowish free-floating lesion in the vitreous cavity. Alongside this, there was inferior pre-retinal fibrosis and occlusive vasculitis. She had an OCT scan in her right eye, and this showed mild macular traction and a lamellar macular hole. So these findings were very suggestive of intravitreal cystocorosis. Are you able to play the video for me, please? So the patient was then taken for transconjunctival 23-gauge 3-port pars plana vitrectomy. She had a core vitrectomy done with removal of the vitreous around the lesion, and then the cyst was removed using a vitreous cutter, which we can see being done here. So following the cyst removal, the posterior hyaloid face was stained with trimacenolone acetate, and this was then carefully removed without causing any retinal breaks. She then had an internal limiting membrane peel, which is what we can see being done now, with caution to spare the fovea. Fluid air exchange was then completed, which we can see in this clip. And then there was endolaser around the occluded vessels before the case was neatly concluded. So post-operatively following her up, the 6-week post-op follow-up shows a fully attached retina and a visual improvement to 6.9 unaided, where her previous was 660. At this stage, she also had an MRI brain scan, which showed findings, so cystic lesions in keeping with spread of the cysticosis to her brain. And Dr. Michael has referred her on to neurology for further workup and diagnosis. Just to wrap up, I would like to share 2 similar cases from the literature. So this first one is from BMJ case reports, a case of similar presentation. So we have a 34-year-old male. He presented with his main complaint of visual deterioration in his right eye for 6 months, and he had an associated scotoma in the superior visual field. Similar to our case, he had a cystic mass seen in his anterior vitreous on the slit lamp exam, but the OCT scan in his case revealed a full-thickness macular hole. The focal area of the RPE was 740 microns, and he also, as you can see in figure 2 on the side, a focal area of RPE thickening. Similar management, the patient underwent the 23-gauge pars plana vitrectomy, cyst lysis, and he had an inverted ILM flap over the macular hole. Now, interestingly, in this case, the authors hypothesized that the macular hole was due to the migration of the cysticus into the vitreous cavity from a subretinal location. So this is thought to be because in ocular tissues, the macula has been noted to be the preferred site for lodgement of the blood-borne cysticus, and it's thought this could be due to the rich blood supply. So it's always worth looking at the macula. The second case is a little bit different. So this is from the Indian Journal of Ophthalmology. This was a case in an 18-year-old male in India. And actually, he presented clinically with findings in keeping with neovascular glaucoma. So in the top image, you can see the slit lamp examination, which has showed ciliary congestion and corneal edema. However, what gave the underlying diagnosis away was the fundus examination, which had that characteristic white opaque cyst. But this patient also had an MRI brain scan, which showed the cystic lesions, therefore confirming the diagnosis of intravitreal cysticosis. Treatment, again, was the same surgery as I've already shared with you. However, this patient had the additional treatment of anti-glaucoma treatment, as well as a trabeculectomy with mitomycin C and an intracameral injection of which was put in as well. And his IOP has recovered nicely from 44 preoperatively to 13 post-op. Thank you very much.
My pleasure to introduce Dr. Michael Mikael. Dr. Michael is a VR surgeon at Kabgayi Eye Unit and the Vice President of the AOC for Northern Africa. He will talk on his journey at Kabgayi.
Thank you very much, and I would like to thank everybody for making this a fantastic day. Can you start my presentation? So, this is my journey so far. I don't know what's next, but did medical school in Egypt, almost 20 years in the UK, and here I come at Kabgayi in April 2022. So although I came here like a week before dragging the whole family with me, I didn't know what to expect and how my life would be. But I'm just exploring with you how the journey was over the last 2 years. So I've been very busy. We are two only VR surgeons, Dr. Peter and myself, not only in Rwanda, but the most of neighboring countries. I did over 800 cases over the last 20 months, lots of outpatient consultations, everyday surgery with a sore neck at the end of the day. It's been a very rich experience. All these people came and supported me, and lots of networking, lots of sharing knowledge and skills, and it's been great. So now the serious stuff will start. This is a patient that I will never forget because it was a turning point in my journey here. This is a young chap who has had a penetrating eye injury 2 months before I saw him. And I didn't think too much of it. I thought this is just a tractional vitreous incarcerated into the rupture site. So we had a corneoscleral laceration that was repaired. And I just went in to explore this eye. So here I'm starting my vitrectomy, just doing a little bit of core, and then I was brave enough to explore this area. And here I find a huge stone inside the eye, and I'm still in denial, carrying on with my vitrectomy, pretending I had not seen anything dropping on the macula there. And I spent 2 hours trying to remove this. Teresa will remember this case because I discussed with her. And then a week later, somebody gave me an advice to go inside the eye with a Prolene suture on a sliding knot. And I'm trying my best to wrap around it. I had to enlarge the cornea, pulling up with my assistant, pulling with me. Then I brought it to the iris plane, lots of viscoelastic above and underneath. And here I delivered a baby boy. So I was so shaky, but it was good. So I took some interesting glaucoma. So if any glaucoma patient comes my way, then I treat them. So I did a trabeculectomy on this patient. And the first week after surgery, she was a hypotony, pressure of 0, choroidals. And I think if you work in Africa, you need to have a problem-solving approach. So here I said, after a week of trying viscoelastic in the AC and just marinating the eye with steroids, atropine, all the rest, I decided to explore the trabeculectomy bleb, and you can see where I put this black mark, there is a leak there. Now, normally, to address this, you need to patch it with tutoplast or a sclera, and obviously, we don't have any of that in theater. So I decided to take part of the same patient eye, part of the sclera, and patch it on the hole. So I do this a lot for the buckles, but I just try to do it for this leaky trap. So here I cut it, stitch it up, close, and she did very well. Within a day, hypotony gone, choroidals gone, and she was happy. So the other thing that I found myself very uncomfortable with lots of pediatric surgical retina. So in the UK, apart from the usual young chap with your young patient with retinal dialysis or atrophic hole, I did not do any vitrectomies on a child. And here I come to Kabgayi. Every week at the beginning, I would have 5 or 6 patients with ROP at my doorstep every week. So I had to learn how to deal with them. So this is just a diagram just to show what is a histopathology or pathology inside the eye. You've got fibrous bands connecting everything together. Ridge to ridge, ridge to lens, ridge to aura. Everything is connected together. And the surgery is simple in the way that what you need to do is just simply relieving this or cutting this kind of fibrous bands. And if you do that, then you save the eye. Dr. Sylvain, who used to be my predecessor, I think he was like having too many patients, so he did operate on one eye and just one eye at a time and left the other eye, no operation. But when patients came back, I realized that the eye that is operated is growing and the eye that was left is shrunken. So the other thing is, one thing I do before I operate on them, I examine them very carefully because you need to see where the traction is. This is a temporal traction. If you put the trocars in the normal place, you will easily end up under the retina and causing a retinal break. And usually for these cases, it's a game over. Retina break is a game over. Eye is gone. So what I did is I did a nasal vitrectomy. So we're talking about temporal small incision this morning. Now I do a nasal vitrectomy, trying my best to get my legs under the table so I can do the surgery. And this works beautifully. This is an 18-month baby with a stage 4B ROP, and he got a tripod of retina. So there is a big stalk going from the retina into the back of the lens and causing the retina to go on a tripod. And surgery, lens-sparing vitrectomy is very good. So you go inside the eye, you do nothing apart from just cutting this. So I'm just trying to cut it with a retinal scissor. And you can see once I cut it, there is a huge gap in between, which tells me that this retina has been pulled up too much by this stalk. And you can imagine this only an 18 months baby. So in a few years' time, the eye is going to grow, and this pulling is going to continue. Another baby, 6 months, bilateral stage 4A. So you can see there is a fibrous band between two folds of the retina, and there was also a band going back into the back of the lens. So again, I did a lens-sparing vitrectomy. Here with a forceps, I'm trying just to cut this connection. You don't need to do anything else. You don't need to do induced PVD, you don't need to pull on the retina. You just cut whatever you see as a source of traction. And once you're done this, your job is done. Then I do a little bit of core vitrectomy. I let some air inside the eye to avoid any vitreous incarceration into the wound, and that's about it. This is the second eye of the patient. So I did bilateral lens-sparing vitrectomy at the same setting. The left eye has got the same configuration with a little bit of vitreous hemorrhage. And between the two ridges, there is a bit of traction between the two. And again, same technique inside the eye, a little bit of core vitrectomy, clearing what I see as a visible traction. And then this one is like a diabetic delamination or segmentation. You just cut this band, cutting all this, and then air go inside the eye, and that's about it. Nothing else needs to be done. And this is the two eyes, only 2 months after surgery. Now, we come to the more difficult, which has a lot of like a steep learning curve for stage 5. You can see that this report from the UK was published very recently, and I circled here that their first line in the conclusion, they said, surgery for stage 5 ROP is not worthwhile. And I completely disagree with this. So when I asked Shane Wong, who came and worked with me here for a week, I told him, what do you tell the patient? He said, I tell them it's a 25% chance of perception of light vision. So is it worth it really? I think it is. So it helps the patient to orient in relation to time, so they know when to wake, when to sleep, and also in terms of space within the house. And this is a 3 months baby, bilateral stage 5. You have to remove the lens, otherwise you can't go inside the eye. You have to remove this fibrous traction behind the lens to divide it somehow. And this is only 2 months after surgery. This is a very fantastic outcome. You see the nerve, you see the macula, the luteal pigments are there, and this is only 2 months. Once you relieve the traction, it sits back. No need for any tamponade, nothing, just like that. Okay, this is another baby I did, 9 months baby. You can see, you can't see any details whatsoever. You don't know where the retina, where the disc, where the macula. I did the same lensectomy and removal of the stuff, and this is how it looks after surgery. So, in conclusion, my life at Kabgayi is interesting, is enriching, is innovative. I feel blessed to be here, and I want to thank
Thank you. Oh, yes, the kids. The whole family. Would the family come to the stage and we can give a clap, please? Come on, Michael, come on. Thank you very much. Thank you, Michael. That was great. So our next speaker is Dr. Theophile Tujisavi, and he will present on traumatic wound dehiscence after cornea graft case presentation. And Dr. Theophile, you all know, is the director of Kabgayi Eye Institute.
Yeah, good afternoon once again. After this good story from Dr. Michael, now I'm going to take you through some untold stories, what most of us we don't like to talk about, but it's the reality. Yeah, so cornea transplant and then traumatic wound dehiscence. As some of you know already, the eye is the third most affected organ by the trauma. And of course, the trauma will be among the cause of blindness. And it will always affect the weakest points of the cornea. So after the cornea transplant, especially for penetrating keratoplast, they are always associated with traumas. Why? Because they decrease the strength at the graft-host junction. And the incidents, when I was looking at different publications, which are not many anyway, but they represent like those traumas may happen from 1 to almost 5%. So the cornea wound dehiscence is a well-known potential complication after PKP, and it's a serious concern because it can end up by severe damage of the ocular structures and permanent decrease in visual acuity. Wound dehiscence may be caused by either a trauma or just after removing the suture, if we're not careful. So some of us maybe know, but if we do the cornea transplant, you can have the full thickness, or you can just have a part of the cornea. So our experience here, last year we had a chance to do some cornea transplant, even though it's not easy job because we don't have availability of the tissues is a problem in the whole country. So we might do 39 cases of cornea transplant, in which 20 cases were penetrating keratoplasty as a technique, while 19 were just lamellar keratoplasty. Unfortunately, among those 39 cases we are following up, 3 of them had severe injuries after the cornea transplant. The first case was a young boy, only 10 years, who had bilateral keratoconus, severe keratoconus, decreased vision due to keratoconus, and a very successful surgery was done, and we had the hope the vision may improve. Unfortunately, the next day, when he was with his friend at the hospital, they were playing, then he got an injury on that eye. So the crystalline lens was found on the ground. The suture, all those sutures were broken. And of course, eye femur, vitreous hemorrhage, everything was seen as a result of that trauma. So we tried to do cornea resuturing, anterior vitrectomy, as well as posterior vitrectomy, as Dr. Pitt was advising us to do. And today, even though the graft is on, the best corrected vision is only counting finger. So whatever the effort made to save the sight for this young man ended up by losing his vision due to this trauma after the surgery. The second one, this really makes my life very difficult because she had only one eye. The other eye was eviscerated 20 years back. So we did a good surgery. Everybody was very happy because she could now, I think she developed something like sympathetic ophthalmia with posterior synec and everything, cornea scarring. And when we did surgery, the vision was improving. 2 months later, she came back after she got a trauma, and we couldn't see the crystalline lens. The sutures were broken, vitreous hemorrhage, which was spontaneously resolving, so we didn't do vitrectomy. And today, she's aphakic, but she can see only counting finger at near. The disc is pale, so it's difficult for us even to plan for the second IOR because there is no hope. But after the surgery, the life was really very good for her. And unfortunately, this accident came in. The third one, this is 22-year-old lady, also with bilateral keratoconus. She was lucky because we did the dark lamellar keratoplasty. And 4 months later, she had a trauma. But for her, she had, of course, sutures were broken, but the other structure were intact. So we had to resuture, and the vision, she's regaining the vision as well. So even though it's still 636, but at least is better than nothing. So we recommend the followings, knowing that there is evidence that having a PKP can be followed by those traumas, and then at the end of the day, loss of the vision. If it's possible, to have the clear shields which can help our patients, especially for the young children. Because after the surgery, the journey continues. They continue to play. So if you don't protect the eye, they end up by losing the eye and makes the doctors to be uncomfortable. Education is very important when we are doing this kind of cornea transplants. Why? Because, as I said, this eye is very fragile, so we should educate our patients wherever they go to take into account when there is a fight, they are in the bar somewhere, they should know that they are privileged to have that eye, but your eye which is very fragile. So any trauma may finish their life. But also the protective goggles or spectacles after the surgery or some days after the surgery, even a long time using the spectacles. Why? Because this may also protect to get those kind of the injury. And of course, as most of the surgeons know, dark is still safer than PKP. Thank you very much.
Thank you, Theophile. We continue with the rapid fire. It's my pleasure now to introduce Dr. Angela Birungi, who is a resident from Mbarara University in Uganda. And as she gets ready, do we have other visitors from African countries who have joined us today? We want to give you a clap. Other African countries, not Rwanda? Okay. Let's continue, Angela, and I hope they won't be shy to reveal themselves.
Thank you very much. Thank you for the introduction. So I'll present a status update on corneal transplantation in the COEXA countries. No disclosures. So the objective of this survey was to determine the capacity and barriers for corneal transplantation in Eastern, Central, and Southern Africa. And the methods, this was an online cross-sectional study that was carried out for the calendar year 2022, and a number of countries participated in this survey, including Burundi, Ethiopia, Kenya, Malawi, Rwanda, Somalia, South Sudan, Tanzania, Uganda, Zambia, and Zimbabwe. And the data that was provided was given by corneal surgeons, the hospital directors, or eye bank administrators. And the data provided was about the number of corneal transplants that are done in the different facilities. We also looked at the indications for the transplants. We looked at the backlog. We looked at the capacity, the people available to carry out the transplants. So the corneal transplants done versus the backlog, and the backlog referred to the number of people who would require to have the surgery, but they didn't have it done due to a number of reasons. And Ethiopia is doing the highest number of corneal transplants as per 2022, but also we see that despite the high number of corneal transplant surgeries that are done, we still have a very huge backlog, that is the orange. And as we see for Rwanda, the reported number was also low. I think it was about 40, and also with really a big backlog of patients who require this surgery. So the types of corneal transplant surgeries done, the leading is still penetrating keratoplasty, followed by the lamella, the corneal patch, endothelial keratoplasty, and others. So the source of tissue, this is really, really very important. And we came to realize that Ethiopia is doing a very high number of corneal transplants, and we related that to availability of a local eye bank. They are able to do corneal transplants also as emergencies. Dr. Theophile has presented cases of surgery. There are patients you receive and you need a corneal transplant as an emergency management. But in an area where there is no local eye bank, that can't be done. So as we see, Ethiopia has a local eye bank, and they're able to do a number of corneal transplants using the locally retrieved corneas. However, they still also import a number of the corneal tissue. And also, as we see for Rwanda, all the corneas that were used for corneal transplant in 2022, they were all imported from outside Africa. So the indications for corneal transplants, one, the highest reported was microbial keratitis, followed by trauma. And now, in many cases of trauma, actually these patients need to receive the corneal transplant as an emergency surgery. But in the absence of an eye bank, it might not be possible. So bullous keratopathy and then keratoconus. So the barriers to transplantation, the biggest is costs. Patients have to pay to be able to get this surgery. And the high cost, we also think, is because we have to incur the costs of importing this tissue to bring it from outside the continent into the continent. There is a lot of logistics that is involved. And then the tissue itself, the fact that it has to be imported, the waiting time is long. A patient might take around 2 to 5 years to be able to get this surgery. And then the other is the surgeons, the people who are available to do this surgery. And not very many ophthalmologists are conversant doing corneal transplantation. So this is also something that has to be looked into to be able to mentor the young colleagues to be able to do the surgery. And then other issues like lack of a legal framework to be able to allow different countries to retrieve tissue locally. Because without a legal framework, then the country might not be able to do the local retrieval. So any barriers that are really specific to Rwanda, well, none is specific. These barriers cut across the other countries within COEXA, issues of lack of tissue, a lack of a legal framework. We are happy in Uganda, the law was passed in 2023 that permits the organ and tissue transplantation, but that is still possible for living donors. For cornea, there is still a long way to go. So despite the presence of a framework, we are not yet able to do local retrieval. And then the inability to meet the costs, and then lack of corneal surgeons to be able to do the procedure. So in conclusion, the unmet need for corneal transplantation is still alarming. Very many people would benefit from this sight-saving surgery, but they're not able to. And therefore, there is need to increase corneal tissue retrieval within the COEXA countries. And this can only be achieved through setting up local eye banks and training more corneal surgeries and colleagues to be able to carry out this surgery. Special appreciation to the COEXA secretariats and all ophthalmologists who provided data for this online survey. Thank you very much.
Thank you very much. It gives me great pleasure to introduce our next speaker, Professor John Kurikie. He will be presenting on management of keratoconus in Rwanda, where and we. Professor John is an associate clinical professor of ophthalmology and senior consultant ophthalmologist, and a very well-known anterior segment and cornea surgeon in the region. Professor Kurikie has been a key driver in eye care, in the planning and development in Rwanda. He is the co-founder and director of Rwanda International Institute of Ophthalmology, the RIO, and serves as current president of the College of Ophthalmologists and East, Central, and Southern Africa. So thank you very much, Professor John. We are all very keen to hear your lecture. Thank you.
Thank you so much. Good afternoon again. There's some technological issues. So after diving into the vitreoretina for so long, we are going to start surfing now on the cornea. So we are going to talk about the management of keratoconus, just as an overview. As you may know, in 2014, a group of about 39 ophthalmologists from all over the world, except from Africa, sat down and defined what they call the global consensus on keratoconus. The consensus was on 3 issues. The first one was definition and diagnosis of keratoconus. The second one was non-surgical management of keratoconus. And the third one was the surgical management of keratoconus. So for those of us who are not part of that global consensus, is it global for us or is it not global for us? So does the global consensus apply to us? And we're going to see a few things. So we are going to talk about why do we focus on keratoconus? Is it really a serious problem for us? And then we're going to go through quickly about the diagnosis based on the global consensus. And then we'll talk a little bit more about what the global consensus gave us as conclusions and how are we doing versus that global consensus. I'll go very quickly. I'm not going to take hours. It's just I was given 20 minutes. And then I talk about what will be our ideal situation if everything we need was in place. And then we'll have some conclusions. So the pictures you see here are from my patients. So why keratoconus? Is it a serious problem? Yes, for me it is. The only problem we have, as Eli presented this morning, we don't publish our data. So when they talk about the prevalence of keratoconus in the world, actually the global consensus in the definition talked about some factors, and they talked about genetic factors, and they talked about Asian and Arabic population as a factor for high prevalence of keratoconus. Because Africa was not represented, of course, that doesn't appear. But from our practice, all of you who practice in Africa, you would agree with me that the published prevalence in literature is actually much lower than what we see in our practice. So if you see this child of 8 years with acute eye drops, at 8 years, so when did this keratoconus start in this child? Maybe when he was 3 or 4. So when we talk in the literature about the onset as puberty, maybe we are a little bit off. So in our settings, it might be very different. So if you see a child like this, any child who can be denied the opportunity to go to school, even if there are not many, it's a serious problem. So for us, we take it as a serious issue. So how do we diagnose? So most of the clinicians who work in district hospitals or not in very specialized centers will do clinical diagnosis of keratoconus. And the clinical diagnosis is always positive when it is a bit too late. When many things which could be done for these young patients are no longer an option for them. So it's therefore it's critical to be able to diagnose early at the pre-clinical stage so that early interventions can save the vision of these young patients. The picture you see there, it's actually not on a slit lamp. It's a picture I took with my mobile phone. So you can position it in a way that you can actually capture the cone, even at an early stage, not so early, but when the cone is actually there. So for those who don't work in specialized centers again, we can have some reason to suspect our patients of having keratoconus and send them for further assessments in the centers where it can be done. So if you have a child with a reduced vision, high astigmatism, especially with myopia, when it's hyperopia, I haven't managed to get any patient who was diagnosed as keratoconus later on. But high astigmatism with myopia, suspicion, when you have non-inflammatory thinning, if you suspect there is a thinning of the cornea, especially in the background of allergy, you should send this patient for screening. So if we had a screening program, these will be the criteria for us to send the kids for screening. Where they have means, you can go all the way from doing a keratometry. I'm sure the young doctors nowadays don't know what the picture up there is, because they are using now the automated. They don't use the manual keratometers anymore. So those are the pictures we get when we do our manual keratometry. So keratometry can give you some idea, but you have to go through different investigation processes. The current gold standard being the cornea tomography. Cornea tomography is now the current gold standard because in the consensus again, there is no definition of keratoconus without changes in the posterior surface elevation. That is one criteria which, when it's not there, you can't say it's got keratoconus. Therefore, tomography is of essence. So the tomographies we have, there are many. Most of them are sham camera based. The main ones are the three you know there, Pentacam, Galilei, and Sirius. I'll talk about Sirius more because the one I know more, the one I use for the last 12 years. They are there, different types. At the moment, we have new ones which combine topography with OCT, which gives you much more details than what the tomographies are giving you today. But these are still very expensive, not affordable. So when you look at the ones we use in a serious CSO type, there are different indices that you have to capture to be able to diagnose whether they are doing a screening for keratoconus or if you are going to take a decision for treatment. So for screening, the highest sensitive indices for keratoconus, it is the Biocchi, Calosi, Versace front and the symmetry index front. Will give you almost 100% sensitivity in terms of screening. But when you want to treat, you look at the specificity, and the highly specific are, again, the symmetry index at the back of the cornea, the Biocchi, Calosi, Versace front again, and the 8 millimeters RMS versus A, which gives you the highest specificity of keratoconus. So you look at the indices on the maps. You'll have the shape indices. Then you're going to look at the keratoconus indices. Then you have the cutoff measures that the cutoffs are there. You can use them to know whether it is a positive suspect or a positive confirmed keratoconus. So these are the maps you get, and you have those indices there, and you can decide whether the patient is normal or not normal. So this consensus. The consensus, as I told you, was about 36 specialists from Asia, from Europe, from South America and South America. And they designed this flow chart on how do you take decisions on keratoconus. So starting by treating allergy, going down, giving glasses, if not, go to cross-linking. If not, go to scleral lenses, go to the intracorneal scleral rings, stroma rings. Although you go down until you reach the part of transplant. So all these are good, and all these are things that are somewhere available, somewhere difficult to. You saw the talk on transplants, but there are some issues. So the first one is you can do cross-linking. Yes, most centers now have access to cross-linking, but in the Coexa region, there are not so many centers that can do cross-linking. But the cost at the moment, I estimate it at around $300 per eye. To do scleral lenses, it's now the way to go. You do cross-linking, then you do scleral lenses to give a good vision. Scleral lenses, again, at the moment for us to access them, it's around $1,000 per pair. When we do transplant, you understood where are the problems in terms of supplies, in terms of the number of surgeons, and then the cost. The cost today, if it's not subsidized, it's around close to $3,000. And then if you do the intacs or the intracorneal stroma rings, that is also an option in early in the problem, but all these also will cost you around $2,000. So the consensus is there. The consensus is good. We've tried all the aspects of the consensus, but how many patients can actually access this? So I think in the ideal situation in our setup as Rwanda is we should have a screening program for kids in schools to diagnose keratoconus very early. But for this to happen, we need to have a portable topography machine, if possible with artificial intelligence associated with it, so that you don't need to send to the specialist. Then you can now diagnose early, do cross-linking early, give glasses, or if possible, give the scleral contact lenses. Unfortunately, the cost is still a problem. The mutual, which is the community insurance, doesn't cover all of these procedures. And therefore, it will remain available for a few who can afford it or who have private insurances. So we should aim at minimizing the number of transplants as much as possible in keratoconus patients. This can only be done by early diagnostic and then intervention very early in the process. So the next global consensus is coming from this year to next year. So Africa will be represented this time around. So the previous consensus, we have no problem with it. But when it comes to some definitions, some practices, I think we'll have to bring on the table our own ideas on the process. And this consensus will be headed by Dr. Hafezi that you see there from Switzerland. He is the current world leader in terms of cross-linking and all the research happening with keratoconus. So in conclusion, so we are doing well in terms of the global consensus, in terms of applying whatever was advocated. But not so many patients have access to all those recommendations. So our aim should be to screen at national level. We have a national school screening program coming up. We should add keratoconus screening in that national screening program. And if we can get a topographer with the AI, those who are in the industry of selling equipment, please look at it if it's possible. That can be a breakthrough for us. And then if we can diagnose early, do cross-linking early and give glasses, that will be the first option. But if we can give scleral contact lenses also, it will be a better option for vision rehabilitation. Thank you so much.
Thank you very much, Professor Kurikiri. So we are a little bit delayed on this session. Sorry, so we will just accept a couple of questions from the audience. Any pressing questions, and the rest if it can be asked throughout the coffee break that we will have after.
Just a question for Dr. Angela from Uganda. Where was the corneal material coming from that you couldn't get from your own country? You mentioned that you were getting from elsewhere. Where were they all coming from?
Okay, thank you for the question. So from the survey, it was reported that some countries were getting from Sri Lanka, others from India, others from USA. So, yeah.
And this was predominantly not dried, frozen material, this is fresh material. Yeah.
There is a time we used to get tissues from Sri Lanka because it's much more affordable than US, but the quality was not always guaranteed. So for us, most of the corneas we use are from the US. And they are fresh corneas that we purchase, and they reach us within 4 or 5 days after the shipping.
So if there's one other question, pressing question from the audience? Okay, if not, then probably we'll stop here, and feel free, of course, to ask the speakers throughout the coffee break. Thank you.
Thank you so much. Thank you, Professor Naomi and Professor Chiku, for moderating this session. So if you look at the agenda, we have one more session coming up, and we should wrap it up with a good energy. So I am going to allow you to grab coffee and be back at 3:30 p.m. Thank you so much.
SRT and trabeculectomy. Those who don't know who he is, he's a clinical professor of ophthalmology, glaucoma and public health specialist at Belfast Health and Social Care Trust in Northern Ireland. Has been chief investigator in several high-yield multi-center randomized clinical trials, among others the EAGLE study on extraction for angle closure glaucoma. He has published over 250 papers and he's the lead editor of 2020 European Glaucoma Society guidelines. Professor Augusto advises the UK government on the introduction of new surgical procedures and devices in the NHS as a member of NICE. He's ranked number 2 in Europe and number 7 worldwide in glaucoma by ExpertScape. Extending our warm welcome to Professor Augusto Blanco as he takes the stage. Welcome, Professor Blanco.
Thank you very much. Hopefully you won't be very disappointed. Can I thank and congratulate Dr. Theophile for this opportunity. Congratulate him for leading such an excellent institution. I would like to thank Dr. Michael and Marianne for their hospitality and friendship. And I would like to thank Dr. Olivia. Olivia was the one who suggested to explore this possibility. So thank you, Olivia. So we're going to have a brief overview of glaucoma from risk factors, epidemiology, diagnosis, but we're going to focus perhaps a bit more on treatment. So this patient we saw a couple of days ago, and it was very dramatic. This young lady, 28 years old, had been complaining of gradual loss of vision. She went to the healthcare center, they prescribed antihistamine. And when she presented, first time presentation of ophthalmology, she had in the right eye light perception with very high pressures over 40. The left eye, counting fingers at 1 meter with pressure of 28. The angles were open. And of course, this was glaucoma. The discs didn't have any neuroretinal rim that we could see. So can I ask you a question, because this happened 2 days ago. What would you do? Can you raise your hand if you would think that the best option for her would be nothing, it's only medical treatment? Can you raise your hand? Who would recommend trabeculectomy in the only seeing eye? Can you raise your hand? You think that's a better option for her? Yes. Who would recommend perhaps selective laser trabeculoplasty or cyclodynamic laser treatment? So this consensus trabeculectomy is the best option. Okay, last question. How many of you, can you raise your hand if you are an experienced, you do glaucoma surgery regularly? Can you raise your hand? So literally a handful. We need more glaucoma surgeons, right? That's a great need. Okay, so let's start with a brief introduction. I think that you know better than me that the burden of glaucoma in patients, in families, in society, a loss of economic activity. And in Africa, again, you know better than me, that affects young adults. This is Sola. She did a PhD with us just before the pandemic, and most of her PhD was in Nigeria and Lagos. Sola was already an international expert in glaucoma. I'm not sure if she learned much about it, but she had perhaps a bit more time to do some research. And I'm going to share with you some of her fantastic work that has been published quite recently. This is a survey on presentations of over 1,000 patients in 10 African countries, 27 units. Rwanda was not part of it. And also I must say that there are differences between countries. Africa is a great country with different ethnic backgrounds and healthcare systems. But essentially, patients that presented first at diagnosis, nearly 60% had severe disease in at least one eye at presentation. So that's something that you will be familiar with. This is a very important and useful survey that we have also Professor Chico and Professor John here, co-authors or leading authors. And in Rwanda, glaucoma is the second leading cause of blindness, but is the leading cause of irreversible blindness. So we are talking about a serious issue. And I don't know why Michael put us last in the day when, so I still have a grant. He was telling me, well, we always leave the best to last. I'm not sure about that's the case. Anyway, here we are. Detection of glaucoma, screening the population is probably not feasible. Even in wealthy countries, it's not considered cost-effective. Sola was working on building, information where you could potentially model, but it's quite challenging. But there are other ways of potentially reaching out people before they have end-stage disease. And it was mentioned before by Professor Chiku that perhaps AI, perhaps in outreach clinics that are potentially detecting cataract, we could potentially have a camera and use technology or the people or healthcare assistants. Potentially targeting high-risk populations. So this girl who was here with a couple of days ago, someone asked me, did you look at the family? And I say, I forgot. So perhaps, we should have a strategy. Someone who presents with severe, significant disease potentially have a genetic component. We should, this in the clinic, but also as a policy. Opportunistic detection when they're testing for presbyopia. And education of healthcare workers, education of the public. This is an example of these outreach communities for cataract, and again, work on SOLA, testing for screening or detecting glaucoma, and that was quite effective. So that's a model that perhaps is potentially worth exploring. Another option, this is of course, in some countries, surveillance or screening of diabetic retinopathy is done with pictures, perhaps not AI yet, and the pictures are graded by technicians or graders. And we try, okay, perhaps we can develop a training module and test if graders can detect glaucoma. So we have an arts, and this participating also with the group from Melbourne and with Michael Coote. So this is the question. We have a large number of different optic discs with different ethnic backgrounds, and the questions would be the technicians, would you refer this patient you think potentially is glaucoma? And they did quite well. So it's potentially possible to train allied healthcare professionals. So diagnosis of glaucoma, again, until we get a proper AI, I think it's still a clinical examination of the optic disc. And that's the key test. And of course, sometimes it's difficult. I was in the clinic this week, and a lot of people, well, my impression, again, I don't have a lot of experience, but there is a lot of large optic discs and with thin rim, and sometimes difficult to not rule out glaucoma, but of course if they are symmetric, both eyes look the same, the visual field appears is normal, so okay, then I'm confident it's not glaucoma. But still, again, is the main diagnostic test. Visual field tests is challenging for people that, for first presentation, perhaps people from rural communities feel a bit overwhelmed, in front of something that's very unfamiliar. OCT, of course, OCT is useful, but it's not a good diagnostic tool. There is a lot of red quadrants. Of course, it's useful to triage. If you have a red quadrant, okay, that's something that perhaps we want to pay a better attention to the clinical examination, but it's not a good diagnostic test in the community or first presentation of glaucoma. And IOP, again, I have the impression, and I was talking to some of our colleagues, that there is a lot of people with glaucoma with low pressures. But still, those that have high pressure are more likely to progress rapidly. So IOP is not diagnostic, but it still helps to risk profile a particular person. Okay, let's talk about management. It was a long introduction. So this is quite simple, but perhaps we can stop here for a second. Management depends on the severity of the disease. I always tell my trainees there are two types of glaucoma. severe and the non-severe glaucoma. The non-severe glaucoma is a very forgiving, typically on treatment is a slow disease, not always. That's another challenge, but from a public health perspective, the main challenge is those who have severe disease. We know that they have a high risk of blindness, or if they are perhaps there already. So, I was talking also with Ellie and with David, what target pressure? And target pressure, of course, depends on the baseline pressure, depends on the severity of the disease. What I'm trying to say, you have severe disease, you have to reduce the pressure very substantially. And you have a high pressure glaucoma, you need to bring the pressure around 10 or lower. If you have a low tension glaucoma, you have to reduce it a lot, certainly going into the single digits, and I don't know, again, I was talking to some of my colleagues, why would that be, why is it so prevalent? Is that because the sclera is thicker? I mean, there's something about the characteristics of the eye that makes it more vulnerable, perhaps the size of the optic disc, I don't know, but I don't think we know. Okay, another great work from SOLA. This is again glaucoma treatment patterns in 10 countries, the same group. And again, forgive me, just to generalize because the countries are all different. But essentially, what she was trying to do is, for example, is laser available, widely available in these countries? Laser. And you see here, access. It's about 60%, which is, I guess, not bad, And surgery, of course, and medication was available in the vast majority. But what's interesting also is this hasn't been published yet, has been submitted, but I'm happy to share this with you. What is the acceptability of the treatment that we recommend? And again, it depends on the country, depends on many factors. But this is a global figure. You look here, again, the surgery is challenging. You see here in this part of the screen. So, maybe 30% will refuse, and the fear or cost are the most important factors. And surgery, I mean, it's really a hard sell because glaucoma surgery, trabeculectomy, which is what we need in people with severe disease, if everything goes well, the patient will see a bit worse and will have an uncomfortable eye for life. So, and that's, why the trust in doctors is important, and education and communication. It's very different, it's very ungrateful compared to cataract surgery that you have, happy patients. So, SLT, we're going to talk a little bit about SLT and a bit of surgery. SLT is a game changer. I'm so happy that there is an SLT in Kigali. If you think from a public health perspective, if you do a lot of SLT, you do SLT to everybody who has glaucoma, you're going to decrease glaucoma blindness substantially. SLT is safe and is effective. It's not as effective as in everybody, and it's not as effective as surgery. But it's something that, we should try to do more SLT. Of course, I know that Timolol and latanoprost are available here in Rwanda, and I was thinking, probably you don't need more. I mean, you may be aware that in Europe there are carbonic anhydrase inhibitors, there are alpha agonists. They are not very effective, and they have a lot of side effects. So if you are not well controlled with Timolol and latanoprost, you are not missing much. I think that we need to think at other options as we do there. SLT. Well, the SLT, of course, is nothing new. Argon laser trabeculoplasty has been used for glaucoma for many decades. And there are trials comparing argon laser trabeculoplasty with Timolol 40 years ago that show that argon laser trabeculoplasty was more effective than Timolol. Timolol was the best available treatment, again, 40 years ago. And the adoption of argon laser trabeculoplasty was very variable and depending on many factors, but the evidence was there. And what happens with the SLT is that SLT doesn't, well, there are some potential theoretical advantages that doesn't destroy the trabecular measure. But the most important advantage, in my opinion, is that it's easy to deliver. You don't need to be a very good surgeon. You know, argon laser trabeculoplasty, you have to use a 50 micron aim to the anterior segment part of the trabecular measure. It's very difficult to learn and to master. SLT has a 500 micron. Essentially, just aim above the iris insertion and you will hit the trabecular measure. And that easy of access, potentially you can train, I mean, you can generalize, you potentially think in training allied healthcare professionals if they know how to do gonioscopy. So this is the landmark study. There are many trials, and there is, of course, also systematic reviews. But this is the one trial that really changed, current practice in all over the world. And this, our unit, I was not an investigator, but our unit was recruiting for the trial. And essentially, people who are treated with SLT compared with standard treatment in the UK, in the SLT group, they do better. After 3 years, 3/4 of people don't need any treatment. These are people with mild glaucoma and ocular hypertension, okay? But after 3 years, two-thirds don't need any, or no, more than 2/3 don't need any treatment. So that was quite remarkable. And in the long term, there is also a difference in disease progression. You probably are more aware than me about this trial here in Tanzania, comparing SLT versus 0.5% timolol. So they were enrolled 200 participants. The primary outcome at 1 year was success rate considering intraocular pressure. And SLT is better than timolol in a Tanzanian population. And this is in the context of a trial. This morning someone was asking, sometimes what happens in trials doesn't happen in real life. In real life, people use drops probably less regularly than in the context of a trial. So in real life, I suspect that the outcomes of SLT are even better when compared to medication. Primary surgery, and this is why, we have now evidence, well, at least, maybe not be representative of African populations, but in European populations, we have evidence that in people with severe glaucoma, primary surgery is the way to go. So before it was common sense, the glaucoma surgeons, we all agree that trabeculectomy is the best option, but now we have solid evidence that this is what we should do. Of course, perhaps they are not so severe as the lady we saw earlier, but this is a publication earlier in January in Ophthalmology. This is the first time that a medication versus surgery trial shows that there is less disease progression after 5 years. So this is, you see the visual field MD value diverging, so there is less visual field they're able to do. So this is about 3 minutes. This is all the steps in surgery are important. In phacosurgery, all the steps, from the incision to the variant are important. In glaucoma, all the steps are important, from opening the conjunctiva, closing the conjunctiva. But there's something that I'm very particular about. I was trying to teach David and Ellie. It's just once you put the sutures, I like to use the slip knots so I can see and control how much flow there is. It's still a bit unpredictable sometimes. It gets surprises. Anyway, so what Journey was doing here again, it was a phacotrabeculectomy. I'm gonna talk briefly about phacotrabeculectomy. How we're doing time-wise? Left. Okay. No chance. Okay. Well, there's just these slip knots, and you test. If there is too leaky, then I tie them tighter. If it's too tight, there is not enough leak through you put the fluid through the paracentesis, then you can loosen them. So perhaps we can move on. Otherwise, Jago will be putting me there. Okay. there is a trial on education of training on glaucoma surgical skills. And again, perhaps you know that. And this is later at the London School. So essentially, there is also a glaucoma surgery simulator. And this is the outcome is about some discrete steps. The interventions is 1 week of intensive training with the simulator. And it's a kind of a steps wedge design. So you can see that in the blue is the trainees who are exposed early to the simulator and very quickly within the week reach all the important skills. And the control group, they just continue with the regular training. And again, it's only when they get the access to the simulator that the surgical skills improve. So that's something to consider because it's an African trial, it's a well-designed trial. I also like to do a lot of phacotrabeculectomies, and reflecting, there is no evidence, but people who are above 50 or 60 years of age, they have lost accommodation. Even if they have good vision, if you do a trabeculectomy, they're talking about people with severe disease, you have to do a trabeculectomy. If and when you do a trabeculectomy, a year or two later, you're going to have a significant cataract. Then you're going to do the cataract, and the surgery may fail because of the inflammation. So one possibility is to do a phacotrabeculectomy when the lens is not very advanced, so there is less inflammation. Improve a bit, may correct the refractive error, and then that's something also of value. Anyway, something to consider about. But this is an opinion, and I don't have enough experience to recommend you, and certainly no evidence to tell you to do this. It's just a suggestion. So, just to finish, no time. Just to finish, as you know, Professor Chico was part of this group, and the World Health Organization has recommended essential technologies and tests to do. And in glaucoma now, it's recognized that SLT is an essential equipment to have in eye hospitals. And perhaps you can lobby, your institutions. And that's also reflected here in glaucoma toolkit. The Ministry of Health is probably going to update the strategies. Perhaps there's an opportunity to share, the need for SLT. So in conclusion, well, glaucoma is a major blinding disease. Think about the lady that we shared today. Good training, surgical training is important. Detecting people before they get to various end-stage disease is also, I don't know how to do it, but we should try different strategies. And this is my last slide. Marianne is not here. I was asking Marianne, she was taking a lot of pictures and say, please take a picture because I want to show a picture of me that I look handsome. And she told me, doctor, this is the best I can do. Thank you very much, yes.
I have the honor to present, to ask Dr. Janvi and Niral Karia to go to the stage, and they will present on helping glaucoma compliance with suprachoroidal minimally invasive surgery. Dr. Janvi is a foundation year trainee doctor working at Addenbrooke's Hospital in Cambridge and holds a honorary ophthalmology position at Southend Hospital. She had her undergraduate training at University College in London. Dr. Niral Karia is a consultant ophthalmologist at Southend Hospital in UK since 2003, and he carried out his residency training in London, followed by different VR fellowships in Melbourne, Australia, and in Oxford. We are very curious to hear your presentation.
Thank you. Thank you for the opportunity to present. Thank you for the Kabgayi team for organizing this meeting, which has been excellent. Thank you to Dr. Janvi, who helped to collect the data and look at the case series of this procedure at Southend Hospital as well. So I work at Southend Hospital in the UK. Many of you would probably not be aware of where it is, so I'm sure everyone is aware where London is. Closer in from London, eastward near the coast is Southend-on-Sea, and Cambridge is further north. So that's where we live and work. We have absolutely no financial interests in any of this presentation. Now, as you've heard from Dr. Augusto, we know that the prevalence of open-angle glaucoma has been found to be the highest in the African continent. This paper, which was published in Nature as an open access article, was a meta-analysis looking at over 20 years of data. And it looked at data concerning Africa, but it only looked at data from Tanzania, South Africa, Ghana, Nigeria, concluding that it had the highest prevalence of POAG at 4%. But what about Rwanda? It didn't mention Rwanda. Data from Rwanda is actually not very forthcoming, but I managed to find this published paper, which was undertaken in 2015, and it was a nationwide sampling looking at just over 5,000 cases. Not surprisingly, it found that cataract was the leading cause of reversible visual loss, and surprisingly concluded that the prevalence of blindness in Rwanda is low compared to previous estimates. It further broke this down by cause, and again, not surprisingly, cataract was the highest cause, but glaucoma, surprisingly, accounted for a very low percentage of the cause of moderate or severe blindness in glaucoma. So, in spite of all this, we all recognize that glaucoma poses a challenge in sub-Saharan Africa. There is a higher prevalence of POAG in sub-Saharan Africa. We know our patients present late, and often they present only when they've lost vision in one eye and the second eye is losing vision. They're young. The socio-economic circumstances mean that there is often poor adherence to topical treatment, and you've heard Dr. Augusto speaking about various options. We know that the intraocular pressure is really the best tackled modifiable risk factor to address in these patients. We've heard about SLT, augmented trabeculectomy. They're both good options, but we also know there's drawbacks from these, including efficacy from SLT, the incidence of visual loss, bleb management, etc. from trabeculectomy. These all address the effect of outflow resistance in glaucoma. So, was there any other options? So, this star antifibrotic material was designed in America. It's designed as a medical grade silicone material, which they claim has a precision pore geometry, so that actually 2/3 of the material is actually empty space. The material is very soft, flexible, and friendly to the tissues. The animal studies done on this material, so this is a histopathology slide in a rabbit, and they find that the material sitting in the suprachoroidal space, that's the uvea, actually integrates well with the surrounding tissues. So there's what they term biointegration of the material. So there's introduction of cells, healthy cells into the material, such as macrophages, multinucleate giant cells. And it's the presence of the biointegration that actually prevents the fibrosis and encapsulation of the implant, keeping it patent to flow. So they made a device called the mini-jet from the star material. The material itself is soft, flexible, with antifibrotic properties, and the micropores that I've explained enable a natural flow of fluid over the suprachoroidal space. The surgical procedure can be done as a standalone procedure, can be combined with cataract surgery. I'll explain why I got involved with it in a second. It's an ab interno approach and done through a standard phaco incision. It's usually best access is sitting temporally, and you're implanting into the nasal area. Dr. Sisbro will be very at home with the temporal approach, so this is right down your street. The surgery is attractive because it's bleb-free. There's no issues of scarring, use of antimetabolites, no bleb management, and that's one of the reasons why I'm highlighting it here. Only a small size of the implant actually stays in the anterior chamber. So the delivery system is actually well designed after 2 or 3 attempts at prototypes from the company. You have the actual device that sits at the end. You have a retracting sheath. You have a wheel to retract the sheath and a lock. And it's very easy to hold the actual injecting system. And the implantation procedure, as I said, is done easily to the temporal approach because you've got more room into the nasal angle. You tap and create a cleft, suprachoroidal cleft, insert the injector into that cleft, and there's a green mark on the actual material. So you know that when the green mark is in line with the scleral spur, you can retract the sheath. The sheath doesn't push it, the sheath retracts away from it, so leaves it there. And then you've got the material sitting in the suprachoroidal space. So you may have heard of the SIPAS years ago. It's exactly the same where it's going. The SIPAS was withdrawn due to endothelial fallout issues some years ago. So the reason I got involved, I do a lot of VR surgery. I had lots of patients that come with bad diabetic retinopathy, a lot of whom have neovascular glaucoma. And we treat, even in the UK, neovascular glaucoma, we use Avastin. Our hospital makes Avastin, we treat it, and it works very well to control neovascular glaucoma. Speaking to my colleagues, and we discussed, and they said, Nirul, why don't you try this? We don't want to try it, so why don't you try it? And I thought, well, the device isn't formally marketed for neovascular glaucoma, but I have patients that I've done vitrectomies for or need vitrectomies. I've quietened them down. What about if we use this? Because if we use this, then you don't have to manage their fibrosed blebs and everything. So that's how it came to pass. So this is just a video. You might notice with the eye of faith that this patient is actually not a straightforward patient. You can see maybe fine burnt out new vessels on the iris. So it's not a POAG patient as such, but the procedure is the same. You sit temporarily, put a real view gonio prism on, fill the AC with viscoelastic, puts the device into that, you can see there, and then it's a tapping action to create the cleft, and you'll probably see the cleft forming in a second. You can see the cleft opening up there. And then once the cleft is, you forward the injecting system into it until you get to the green mark, and then retract the sheath out. The hemorrhage is common in neovascular glaucoma patients that I've done. It's less common in POAG, but it does happen, and I wouldn't be too concerned if this clears by the next day. One of my colleagues did a patient who was on anticoagulants, and that patient had a big high femur, which required other procedures. So you need to be careful if they're not controlled on their anticoagulation. So 1 week post-operatively, this is what it looks like. It's sitting in the suprachoroidal space in the scleral spur. You can see the green mark on the implant. This is the ideal way it's sitting, and this is actually a neovascular glaucoma patient. So this patient had a pressure preoperatively of 50. A week later, the pressure was 7 off all drops. So it's a good immediate reaction, immediate response. The STAR trials, STAR 1, STAR 2, STAR 3 trials were done as non-randomized studies. They were looking at safety and efficacy. there were single-arm, non-randomized trials looking at this, and there were sites across Colombia, France, Germany, India, Panama, and Spain, but up to 70% of their patients were non-Caucasian. And they published a meta-analysis of the 3 trials recently in the AAO in Open Access journal, and they found that a good response. So there was a drop in intraocular pressure by 10 with the procedure, and if the patients were taking drops, that reduced their drops average from 2.4 to 1.4, and up to 40% of their patients were free of medication at 2 years. But this was for patients in mild to moderate POAG. These studies have not been done in secondary glaucoma. But there is very favorable safety and efficacy from this procedure. Currently, the actual injection, the actual device is only available in the EU, UK, the Nordic countries, Switzerland, and Australia. But I spoke to the company rep, and he said, yeah, they are going to try and slowly introduce it to other parts, such as Africa. So from our observations, we've done a few more since then, but it is a learning curve like anything, but it's actually very amenable because it takes 5 minutes to do. It's very amenable. If you get favorable prices for this device in Africa, it's very, very easy to do. You can combine it with cataract surgery if the cataract surgery is needed. And from our experience of the cases we've done, the patients with primary open-angle glaucoma do very well with this procedure. The use of this procedure in neovascular glaucoma does need further evaluation because it seems like if the process is still active, you might get overlying fibrosis and the cleft closes pretty quickly, and then you're relying on the technology of the device to allow the fluid to drain across the suprachoroidal space. Although the studies were done in 70% non-Caucasian eyes, we still don't know how African eyes would respond, because I know African eyes behave differently to other types of eyes, as do other types of eyes. But it's definitely a consideration, as there is definitely no blood management. You can still do a trab or your favorite procedure afterwards to address the outflow resistance problems with this procedure. So this is just a slide of the device that I showed you earlier, 1 week afterwards. But 3 months afterwards, you can see it's not so clearly visible. That's the same patient. And this is in a neovascular glaucoma. So this is where the pressure started to go up. So this patient had a pressure of 26 off treatment, having been pressure at about 7, I think I said, at 1 week. So neovascular glaucoma, if you use this, it doesn't need further evaluation. So in summary, the Minijet, it's a suprachoroidal implant. I feel it might be an attractive procedure to consider in Rwanda or an African setting, if the prices are good, if it's economically viable for this country and in neighboring countries. It's worth considering if it becomes available. It's marketed by the company called iStar Medical, which is based in Belgium. If any of you decide to visit the UK and come to the seaside in Southend-on-Sea where I live, I can only claim that Southend-on-Sea is famous because it has the largest pier in the world. It goes out 1.3 miles into the sea, so you can have a nice walk outside. And Rwanda being landlocked, you might want to visit Southend-on-Sea. Thank you.
Thank you very much. We'll ask both speakers to come to the front for questions. I'm sure there are many. How many minutes do we have? 5 minutes for questions. So, Dr. Cropsey.
Dr. Augusto, what is your your post-SLT drop regime, typically?
Continue with the glaucoma medication that has significant glaucoma, but we don't give. No? Actually, there's some suggestion that shouldn't be used. Other colleagues, you could be non-steroidals for 4 days, 4 times a day. But,
So, in the morning we talked about fear of the unknown, and in glaucoma there's a lot of things that we could be practicing on the continent, but we fear them because we don't know them. So SLT and all these mixed procedures fall into that category. And it's maybe time to change the paradigm where everybody knows that there is most glaucoma in Africa. But when these things are being designed and tested, we are not that included into those studies. So if we were, we would fear them less. We have an SLT in our hospital, and it's taken crops is coming to try and make us love it, and we still don't love it because we don't have much experience with it. So maybe for the future in the large collaborations, we are available, we would like to learn, and we have the patient base to be involved in the development of some of these techniques. Thank you. And I enjoyed both your talks very much.
Can I just reply to that? I think you're absolutely correct. If you look at the countries where this iStar, the STAR material was trialed, South America, India, these sort of places, and traditionally these companies go to these countries because they are easy to do trials in these countries. They don't have rules and regulations. You will never find these sort of trials being done in America or the UK as first-line trials. That's the problem. Now in Africa, I think if you are, if it's easy to facilitate these sort of trials, then you as leaders, the COEXA, the council, you should approach these companies and say, look, actually we can do this for you, and there's plenty of need for this in Africa. And it makes sense.
Yes, of course, I agree. And it's so important that we, Africa has so much needs. We cannot necessarily generalize the findings of European populations to Africa, so there is an unmet need. So we need, I guess, to engage and to explore, ways of doing trials for African populations. So yes, and actually, I was going to, in the UK, sometimes the trials we do in the UK, the funders don't allow to recruit in other countries outside the UK. So that's one barrier. But there is also other ways, because the UK and even the NIH, there are potential possibilities to access funding for, for trials, I think, and with an international perspective. So I think we should talk about it because, I am a clinician and, but also I'm academic as you are, and we should find the ways to collaborate more, and particularly around trials. I think that there are opportunities, and certainly it will be very exciting for me personally, and I'm sure for many of my colleagues. So yes, thank you.
I'd like to know if you have some experience about deep sclerectomy and what you could warn us to do if sclerectomy or SLT, according to complications due to glaucoma surgery. Thank you.
So I have never done deep sclerectomy. It's very interesting. I'm going to talk about the European perspective, okay? For some reason, UK and the United States never, with some exceptions, never adopted non-penetrating surgery. But if you go to South Africa or you go, Switzerland, Germany, Spain, they're very popular. And, the surgeons, they wouldn't do it if it doesn't work. It's possible that perhaps doesn't work as well, but there's other benefits. I don't know in African eyes, because this is, again, but what I was always reflecting is that the culture of practicing ophthalmology, or the culture of practicing medicine, is very important in what you do here or what I do. So I train in, in the States, I train in trabeculectomies, and I do that. If I were training with Andre Mermud, I'm sure I would be doing, non-penetrating sclerotomy. So the culture is very difficult to change, but there's also a challenge. We need new surgeries, and I'm so glad that you are, again, we need to try different things with a proper process. We need to find better surgeries, better treatments, so there are unmet needs. But so anyway, so I don't know whether I answered your question, but those are some reflections that hopefully are useful.
Any other question? I don't see any hand up. Yes, one more.
Only because there's no one else. I just wanted to make another glaucoma frustrates us, as you can see. When I was doing my retina study, because I was in the retina and the nerve is just sitting there, I thought, let me also do some work with the nerve. So I thought I would look at the prevalence of glaucoma in this population by grading the nerve on the slit lamp, but also sending all the visual fields to Tunde Peto to grade them. And of all the publications, that one was never accepted in any journal. And I think my critical fault was I put in a statement there saying that the visual fields were unreliable because I believe that the normative database was not representative of my population. And I don't know how the normative database in a Humphreys is created, but I honestly felt something was just not adding up. And so, but we have no choice but to rely on those gadgets that already exist. But do you know where the normative database for a Humphreys comes from?
No, but but it will happen also with OCT. We are using normalized databases, and they are developed typically European or American, or but not inclusive of African populations. So yes, that's a challenge, and I agree with the problem. I don't know about the visual fields, but yes, I recognize that there is a major deficiency there. Yeah, I agree. It's a significant concern.
Thank you very much. Yes.
Sorry, I was just going to say that I share your frustration because you're perhaps submitting to journals which are not African journals, and they may just disregard this as an African. I can understand, but then maybe you should create an African journal.
It's coming.
That's good.
But I also believe that we need to do that if we are to build up these journals. So that's how we are trying. Yeah.
Thank you very much, everybody. This is the end of the session. I pass to the MC.
Yes, another round of applause to our chairs, Dr. Hurie, and our presenters. Wow, what a day. What have we learned today? And ending on a good note and keeping time. You guys, you should clap for yourself. You didn't give me a hard time. You managed time. Maybe one more. If I can ask everybody to turn to your next person. They say that eyes are windows to what? What is that quote? To the soul. But I believe if you look at someone's into the eyes, you can see so many expressions. So I want to diagnose the person sitting next to you to see if you can diagnose satisfaction in their eyes. Can you do that? Yeah? Are they satisfied? Are you guys satisfied? Yes. That's the way. That was the goal. Because we learned a lot. I hope that when we get to convene next time, we'll have explored those, the unknown that we are fearing and the new technologies that we learned today. So thank you all. The next session, which is the last, is the closure. And of course, closing remarks. I would like to welcome Dr. Theophile Yes, Dr. Teofil, you're welcome for the closing remarks, and then we conclude. Thank you.
Wow. Thank you very much for everybody. And with the tool we used to diagnose the satisfaction, I think, and I can feel it, say it with my open eyes, that we tried our level best. So I will feel be blessed if my colleagues who helped me to organize this event are here with me. So please, Dr. Michael, Dr. Levin, Dr. Eli, Dr. David, please come in front. This is a group of 5 ophthalmologists who are working at Kabgayi, not just for curing the patients, but also to look around and to see the different opportunities. And this was the first opportunity to organize a such event, which, as we saw, it went very successful. Please help me to applaud for them. I'm really very happy to see you here, all of you here. For sure, when we had this idea, we thought maybe it will be something for 50 people or less. Those who had the opportunity to visit this hotel, there is a small room down there near the swimming pool where we thought maybe people can sit there enjoying the weather from the swimming pool and looking just at this good environment around Kabgayi. But the time when we sent the link for people to register, we were very surprised to see how people were hungry to learn from this conference. Everybody here committed, worked very hard so that we can accommodate all of you sitting here. So thank you very much for your time, precious time, but also the trust given to us. As I said, this is the first ever conference, so we couldn't believe that we'll be here with this number. So please applaud for yourself as well. Very important point. Those 2 days, Wednesday, Thursday, it was heavily raining here at Muhanga. Then we were afraid. We were asking ourselves, what are we going to do with this rain? But look what God did. We're really very blessed to have a nice day today where everybody can enjoy, chat, networking as much as you can. I hope you enjoyed, and I think also we reached your expectations. Without taking or using much time, I know some of you need to go back to your own places. I also thank the Kabgayi team, which assisted us in different corners. So if you are here, please stand the Kabgayi team who helped us to organize this event. The Kabgayi team. Thank you very much. Murashoboye, mukomerezaho. So then let me also, maybe before we go to the speakers and the sponsors, in Kabgayi, we treat people, but also sometimes we may also reach the other expectations. We are in a Catholic church, so we are very happy to have a choir here, which the choir wants to sing for us. So I may call the choir to come in front and sing.
Thank you. I would like to call Dr. Olivia to come forward. So, also, I want two people who are behind, Dr. David and Dr. Eri. So you are wondering why we are standing here. It's for a few reasons. So we would like to thank Dr. Olivia. In the morning, before attending this conference, I was checking on Google Map how far Dr. Olivia came from. So it's a long way. More than 10,000 kilometers from here. So we were together, is it 3 weeks? Yes, 4 weeks. Yeah. She was together with us for 4 weeks. So it's a long time. We learned a lot from her. So, and my witnesses are Dr. David especially and Dr. Eria. So she's a good teacher, she's a good friend, so I recommend everyone who wants to teach, who has students who want to learn from her. She's a good teacher. She can teach you in a few days and you become expert. Those are my remarks. So Dr. Olivia is our friend. We spent a lot of time together. We enjoyed everything. It's a lot. So the song we are going to sing is from the singer called Rugamba Spirian, is Rwandan, and the song has a Kinyarwanda name called Murumve Twana Twanjye Nabaraza Urukundo. So in simple, Rugamba Spirian was advising us to love each other. He was saying that let's love bind us. That's why the love of ophthalmology make everyone come here, spend this time together with everyone, sharing knowledge, networking, enjoying, and so on. And I hope it is the beginning. So let's sing that song. It's 2 minutes, and we request everyone to stand up. Who know the song will help us, so I'll enjoy it. Thank you.
This says simply, we love you so much. Yeah, let me use this opportunity to thank all presenters. The presentations you made today were really very rich, very good for us to learn from you. We learned a lot, and we commit to apply some of your recommendations to our future practice. We value your time spent through the preparations. Reason why our Kabgayi team prepared some certificates for recognition. So as you may know, we had two groups of presenters. We have presenters and we have keynote speakers. So Dr. Eri will guide us in offering the certificates, and I will ask anybody who comes to take the certificate to stay here for a group photo. Dr. Eri, go ahead.
Thank you very much. Thank you for everyone to attend our meeting. Can I call Professor Augusto? We are not making you the rust now. Kindly. Thank you for accepting to be with us today. Next. Prof. Chikumatenge, thank you for being here with us. Dr. Tres, thank you for being with us. Prof. John Nguriche, thank you for being with us today. Prof. Naomi, thank you for being with us today. Dr. Olivia, thank you for being with us for 1 month. A group photo with the speakers, please. Thank you very much. Dr. Michael, yes. Yeah? Okay. Dr. Teofil, thank you for accepting to be with us and presenting to us. It was lovely to be with you. Dr. Pete Noen, thank you for being with us. Kalangwa Jean Dodier, please come in for your certificate. Dr. Ngabo David. Dr. John Cropsey, thank you for teaching us today. You know, you see the temporal M6, I've been adopted. Dr. Riven Weme, thank you for presenting to us. Dr. Jamvi, thank you very much for teaching us. Angela Merck, thank you for being with us and presenting us today. Dr. Nila Kalia. Dr. Michael. And the last three, not the least, I. Thank you very much. The preparation was
wow. But for sure, if you look around, you saw those preparations, it needed a lot of budget. And we couldn't get this money from our pockets. So, but there are some good people who committed to support financially. So we can't forget. So while we are calling them to come in front, please help me to applaud for them. And I will ask the Director General of Kabgayi Hospital to in offering the for those who contribute financially. So yourself. Do you need me to call your names?
the representative of Ambition, please come to the front.
Francois?
Ambition.
Maybe he's not here.
Dr. Agarwa Eye Hospital, please come in front. Thank you for supporting us. Thank you very much for supporting us. Orchidia, thank you very much for supporting us and travel along from Egypt to attend the conference. Novartis. Thank you very much for supporting us. Very fast, I think, Dr. Olivia. Thank you very much for supporting us. Some people are curious to see what is inside. Even me, I don't know. Wow. Wow. Thank you very much. Ambition Africa, please. Any representative around?
So those are a few among the others who contributed financially and helped us really too much to organize this successful conference. So for the delegates, thank you, Deje. For the delegates, the certificates will be shared online. You will get your certificates and the CPD points as well. Yeah, the Ambition is coming. Francois, please come in front. Thank you very much for your support.
Oh, thank you. Thank you very much for having us. Thank you.
So what else can I say? Thank you very much, and we hope to see you next year. I hope all of you will come back, but I think we need maybe to increase the size of the room. So if you accept, please applaud for yourself. And safe journey back home. See you next year.
Delegates, make sure you have registered for the CPD. We will email you the certificates. There is a group photo for delegates.